Hi everyone, hi, good evening, hi, I hope everyone is able to hear me now. I hope everyone is able to see me now. I'm sorry for the technical delay. Please give me thumbs up if you can hear me, if you can see me, so that I can start without any further delay. So give me thumbs up guys if you can hear me, if you can see me. Okay.
If you can see me.
Finally. So we are back, and yes, we are going to finish off the remaining topic of polycystic ovarian syndrome, my dear friends. Good evening everyone. Sorry for that delay because there was system update and some technical issue with the laptop. So we are back, and hopefully there will be no further delay. Guys and girls, I welcome you all for this session. The session would be divided into two parts. First part, we will be completing the topic called polycystic ovarian syndrome, where we will be talking about the management issues, and yes, we will also be covering ovulation induction topic, which is a different topic in Spiroff, and it's a big topic where we are going to talk about different drugs and the protocols and the regimes. So yes, my dear friends, let us start our session with the topic called PCOS, and I believe you people have understood the physiology, pathophysiology, and differential diagnosis, and the initial part of the topic was covered by Dipti ma'am, and I will be covering the later part of the topic, and that would be about the treatment. Okay guys, in our stream called obstetrics and gynecology, it's very essential nowadays to learn two important aspects of our OBGY. These are aspects of OBGY. First is how to deal with rowdy patients, and second is how to deal with rowdy technical system. So yes, technical system, we have to have little bit of knowledge. Yeah, so there was an issue before this, and thankfully our technical team, wonderful technical team, has solved that issue. I think that was from my end. Laptop was not doing the job properly. So thank you my technical team for doing wonderful thing starting this lecture. So yes, without wasting time, let's begin our session. So my dear friends, yes, okay, yes, our topic is polycystic ovarian syndrome, and we are going to talk about the management. Management of polycystic ovarian syndrome. First and foremost, you know that our patients who have polycystic ovarian syndrome, they come to us with the main complaint of menstrual irregularities, secondly, hyperandrogenism, so androgen excess. Thirdly, some patients come to probably skin specialist and trachologist for alopecia. Yeah, and then infertility. These are the main complaints which the patient would come to us with. Long term wise, there are long term consequences like endometrial, hyperplasia, which we have to take care of. Then diabetes, don't forget, type 2 DMs are more common in PCOS patients. Then it is said that cardiovascular diseases are more common with PCOS patients, of course. Nowadays, see, earlier we used to say that it is ovarian condition. Now we know it's a group of disorders, endocrinal disorders. That is why it is polycystic ovarian syndrome. It's not ovarian disease. We earlier used to say polycystic ovarian disease. Now we say it's polycystic ovarian syndrome, PCOS. And yes, now there is a new hypothesis that there is excess inflammation in the body, and that is responsible for all the bad things happening in PCOS. Guys and girls, so our patients come to our OPD with abnormal uterine bleeding, menstrual irregularities, androgen excess, alopecia, infertility, endometrial hyperplasia would be long-term effects, type 2 diabetes, serious disease would be long-term effects. The treatment modality is basically aimed at lifestyle modification, which is always underrated treatment modality. We always give less time to the patients regarding this aspect of treatment. In fact, it's the most important aspect of PCOS management, that is lifestyle modification. We'll talk about it. Then combined OC pills have a very special place in the treatment of PCOS, plus or minus with anti-androgens. Yeah. Then we have to think about ovulation induction if they have infertility, and insulin sensitizers. In pathophysiology, you must have heard about the insulin resistance excess which is there in most of the PCOS patients. Yeah, guys, girls. So yes, insulin sensitizers do play a very important role in the treatment modality. I am just giving you a broad skeleton of what all treatment modalities we are going to deal with. I said management issues would be aimed at primarily menstrual irregularities, androgen excess, alopecia, infertility, and long terms endometrial hyperplasia, type 2 DM, serious disease. Treatment modality will have 4-pronged attack: lifestyle modification, combined OC pills, plus or minus anti-androgens, ovulation induction agents for infertile patients, and insulin sensitizers. Now let's start with lifestyle modification. Lifestyle modification. We always give less time to the patients regarding this aspect of the treatment modality, but believe me, this aspect has a power to cure the patient right from the basic. Yeah, remember lifestyle modification, remember weight reduction is always the first line management. Weight reduction. If PCOS patient who is overweight or obese loses even 5 to 10% of the body weight, believe me, most of the PCOS patients will start ovulating and their androgen excess would come down. They would have progesterone in their body and good things would happen in their body. So weight reduction is very important first line of management, especially in overweight and obese patients. Yeah, guys, girls, many studies have been done regarding the type of diet they should have, whether it should be low fat diet, low carbohydrate diet, fancy keto diets are also there. But then remember this thing, ultimately what is the proven thing is that net calorie intake should reduce. Net calorie intake should reduce. May it be carbohydrate, may it be fat, net calorie intake should reduce in PCOS patients. Now, is there any role of metformin in decreasing appetite? Yes. But it is not a primary mode. In reducing weight, metformin is not a primary modality in reducing. You don't have to give metformin just for reducing the weight of the patient, though it though it reduces appetite, but it's not a primary modality of reducing weight. Okay, yes, this important fact that net calorie intake should reduce is very important. And yes, brisk walking, yeah, aerobic exercise would enhance metabolism. Yeah, brisk walking and aerobic exercise would enhance metabolism. Yeah, so we are right now talking about the First important thing, that is lifestyle modification. Net calorie intake should reduce. Brisk walking, aerobic exercise would enhance metabolism. 3 to 4 times per week is ideal, optimal aerobic exercise for PCOS patients. Yeah, each episode, each session should be of 45 minutes. Okay, guys. So 3 to 4 times per week, 45 minutes. Obviously they won't start with 45 immediately, they would take some time, but then this is optimal level which is going to help them out in weight reduction and lifestyle modification. Okay, now advantage, what will happen if they lose weight? It will increase sex hormone binding globulin. In pathophysiology, you must have understood that sex hormone binding globulin is the thing with which 80% of the testosterone is bound. Yeah, 19% is bound with albumin, loosely bound, and 1% is free testosterone. If sex hormone binding globulin is reduced, free testosterone is increased, and this is one of the abnormality in PCOS patients. Sex hormone binding globulin is reduced, and because of that, free testosterone is increased, and free testosterone will have all the bad effects of androgenemia. So yes, by reducing weight, by increasing the exercise, and losing weight, there will be increase in sex hormone binding globulin. Yeah, it would reduce free androgen levels. Yeah, I'll write over here that testosterone 80% with SHBG, 19% of testosterone is with albumin, and 1% is free. Yeah, so if SHBG is reduced, free testosterone would be increased. Okay, yeah, so yes, lifestyle modification is an important aspect of PCOS patient. You understood the advantages. Am I correct? Am I clear about this point, guys and girls? Now let us talk about the second point in the management, menstrual irregularities. Now, why will there be menstrual irregularities? You know that menstrual cycle is made up of proliferation, secretion, and menstruation. Agreed? This is normal menstrual cycle. Proliferation is by estrogen, secretion is by progesterone, and menstruation is due to withdrawal. Estrogen will lead to proliferation. So increase in endometrial thickness is estrogenic activity. Then because of progesterone, there would be secretory activity. Yeah, progesterone will increase the vascularity, secretory activity, and you know progesterone is there because of ovulation. And once there is withdrawal of hormones, then there would be menstruation. Okay, there would be menstruation due to withdrawal of hormones. Now imagine there is no ovulation, so only estrogen, no progesterone. So what will happen to endometrial thickness? Endometrial thickness will go on increasing. This is unopposed estrogenic activity. Yeah, there is no progesterone to cause secretory activity. So unopposed estrogenic activity will lead to hyperproliferation, and patient will tell you, doctor, I don't get menses for 2-3 months. And so on. And then what will happen? There will be proliferation in excess, and one fine day the wall will all be shed off because the blood supply cannot match up the increase in endometrial thickness. So patient will still bleed, but that bleeding would be happening not every month. It would be happening after 2 months, 3 months, something like that. Delayed menses would be there. This is called as estrogen breakthrough bleeding. Yeah, very basic thing, na? In our MBBS days, we have understood this, that menstrual cycle is proliferation, secretion, menstruation. Proliferation is estrogenic, secretion is progesteronic, menstruation is due to withdrawal. But when there is no secretory activity because of lack of progesterone, the endometrial thickness will go on increasing. That is the specific reason why we say that PCOS patients have high risk of developing endometrial hyperplasia and cancer in future. Why? Because there is unopposed estrogenic activity. Yeah. So estrogen breakthrough bleeding would happen. Patient would come to you with oligomenorrhea. Doctor, I don't bleed for one or 1.5 months and then I bleed. Some patients come, doctor, I don't bleed for 3-4 months and then I bleed heavily. That is called as oligo plus menorrhagia, also called metropathica hemorrhagica, which is very rare in PCOS. Most commonly we find oligomenorrhea. Yeah, infrequent cycles. Okay, guys, this is most common pattern. Then oligohypomenorrhea may also be seen. Oligohypomenorrhea may also be seen. Now you can argue with me, sir, why oligohypomenorrhea? Technically, when they are taking long time for endometrial growth and proliferation, the amount of bleeding should be more. Why less? Why hypo element to oligo? Why less bleeding even after 2-3 months? This is because of androgen excess. Hypomenorrhea, that is androgen excess, would lead to reduced amount of blood loss. It is well known fact that androgens reduce the bleeding from endometrium. Yeah? Guys and girls, remember, patients would have oligomenorrhea. Secondly, they may have oligohypomenorrhea. These are the most common patterns. Oligomenorrhea being the most common. They may come with amenorrhea. We have covered secondary amenorrhea chapter. You understood amenorrhea is also because of PCOS. Yeah, amenorrhea. Doctor, no menses for 3 cycles or 6 months, whichever is earlier. Amenorrhea may be there. Yeah, guys, girls, they may come very rarely with metropathica hemorrhagica, very rare pattern. This pattern is seen with perimenopausal patients more oftenly due to anovulation in perimenopause, but PCOS patients, this is very rare. Yeah, this is oligo followed by heavy bleeding, what is called a menorrhagia. Yeah, metropathica hemorrhagica, all because of estrogen breakthrough bleeding. Okay, guys, girls, are you all with me? So yes, these are the menstrual disturbances which patients will complain to you of, and yes, believe me, PCOS is one thing which you see day in and day out in your OPD, and oligomenorrhea is most common symptom in irregular bleeding. Right now? See, Hansween, hypomenorrhea is scanty bleeding, that means less than 2 days of bleeding. That hypo element, scanty bleeding, is because of androgen excess. Okay, got it? Very clear. So guys and girls, so these are the patterns which you will see. Technically, oligo is defined as cycle frequency reduction. That means less than 8 cycles per year. Length of cycle is increased more than 35 days. Yeah, 35. Some books have written 24 to 38 is normal, but believe me, more than 35 we should think about oligomenorrhea and the causes. Okay. Yes, oligomenorrhea. Hypomenorrhea is scanty. Less than 2 days is hypomenorrhea. We basically do not see hypo per se, we see oligo-hypo. Doctor, I don't bleed for 2-3 months. Then also I bleed only for 1 day. That is possible. Oligo-hypomenorrhea. Guys, girls. So what's the treatment modality? The drug of choice, treatment of choice, which you all give in your OPD? Combined OC pills. Combined OC pills are so wonderful. They can control the cycles by iatrogenically controlling the endometrium. You are giving estrogen, you are giving progesterone in combined OC pills. What will these estrogen progesterones do to the pituitary? They will inhibit the LH-FSH formation. What will happen to the ovarian cycle? Ovarian cycle will stop happening. What will happen to endometrium? Now, because you are controlling endometrium, you are causing proliferation, you are causing secretion, and once she will stop these pills, she will have menstruation. So 3 weeks on, 1 week off. That's how you give. right? Combined OC pills, so commonly prescribed to PCOS patients for regularization of menses, right? And yes, on addition, if they have had pregnancy and they want contraception, then combined OC pills will do the job of contraception as well. You will say, sir, PCOS and contraception. So many patients come to us, they have had babies and now they have PCOS. Thankfully, they have had babies somehow. They want contraception as well. You should give COCs. COCs are drugs of choice for irregular menses. Yeah. If they are not okay with oral, then transdermals are also available. Yeah. Or nowadays, Nuva ring. Nuva ring is estrogen plus progesterone ring, which has, these rings are to be put 1 ring per month in vagina. They will give 2.7 milligram of estrogen, ethinyl estradiol, and 11.7 milligram of etonogestrel. This is there in Nuva ring. Yeah, guys, this will work for 3 weeks, and this ring will not have any effect in the 4th week. That means the hormones will vanish in the last week. So what will happen? There will be withdrawal, just like normal cycles. Yeah, and 1 week no hormone, that means there will be withdrawal and patient will have regularization of menses. Yeah, so Nuva ring, 1 ring is to be inserted per month. Yeah, vaginal ring. Okay, the transdermal patches are also available. Yeah, Nuva ring is one thing which is happening, so which is the thing nowadays. So we are doing that. Yeah, but most commonly we are giving combined OC pills for regularization of menses. Okay, good evening Dipanjali. Okay, guys, girls, so yes, we are talking about the aspects of PCOS and the treatment modalities. We have talked about lifestyle modification, we have talked about menstrual disturbances. Guys, if endometrial thickness is more than 12 millimeter, there is high risk of endometrial hyperplasia. So you have to rule out endometrial cancer. One very important thing which you already learned, madam had taught you, that postmenopausal figure is 4 millimeter, that you understood. Premenopausal, there is no fixed figure for high risk of endometrial hyperplasia and cancer. But remember this thing, this is given in Spherov, that endometrial thickness more than 12 millimeter is a high risk for endometrial hyperplasia. You should rule out cancer. This is given, but then studies are showing that exact figure is not available. But if examiner asks you, then 12 millimeter is the figure. I'm again telling you, postmenopausal figures are there. Premenopausal figures are not there regarding the cutoff for endometrial thickness. Yeah, it's only when the endometrial thickness is more than 12 millimeter, then you think about high risk of endometrial hyperplasia. You should rule out cancer in these patients. Am I clear about this, guys, girls? All right. Yeah, guys, girls. So after you have understood this, don't you think this treatment modality is just like a symptomatic treatment? If there is a fever, you give paracetamol. Yeah. If there is headache, you give paracetamol. If there is pain, you give NSAID. That kind of symptomatic treatment is there. If there is irregular cycle, you give OC pill. OC pills per se are not going to treat the metabolic dysfunction which is there in PCOS patients. Agreed, na? But then OC pills have very important role, because OC pills regularize the cycles, and don't forget the OC pills have progesterone. Nowadays there are anti-androgenic progesterones available in market which are useful for hyperandrogenic effects as well. So let us talk about the third aspect of PCOS patient, hirsutism. So oftenly you get these young females of 20s and 25s, 25, 26 years, that they have hair growth on their face, on their chin, on their chest, abdomen. So there is something called modified Ferryman Galway scoring system. Yeah, modified Ferryman Galway scoring system. Now this system, the word modified is there. Why modified? That will also be covered. Remember, it covers 9 androgen sensitive areas. 9 androgen sensitive areas. The original Ferryman-Galway score had 11 androgen sensitive areas, and the amount of hair growth was assessed and the figure was obtained. Here in modified Ferryman, 9 androgen sensitive areas are there, and you have to give score of 0 to 4 for each area. Now the areas are upper lip, chin, chest, upper abdomen, lower abdomen, upper back, lower back, 1, 2, 3, 4, 5, 6, 7, then thighs. Yeah, I said upper lip, chin, chest, upper abdomen, lower abdomen, upper back, lower back, thigh, and upper arm. Here, upper arm. So these are the 9 areas which are to be assessed, and based on the score of 0 being no hair growth, abnormal hair growth I should say, coarse, black in texture hair growth is abnormal, male pattern hair growth, and 4 as severe abnormal hair growth. Yeah, the scoring is obtained, and any patient whose score is more than or equal to 8 is positive for hirsutism. Yeah, hirsutism is 8 or more score. Okay, guys, girls, if the score is 8 to 15, it is called mild to moderate hirsutism. If the score is more than 15, it is called severe hirsutism. Okay, yeah. So my dear friends, so there is a scoring system. You know 9 areas: upper lip, chin, chest, upper abdomen, lower abdomen, upper arm, upper back, lower back, and thighs. Depending upon the hair growth, you have to give the score of 0 to 4. And if the total score is 8 or more, she has hirsutism, clinical hirsutism is there. It's a marker of androgen excess. And 8 to 15 is mild to moderate, and more than 15 is severe. Okay, got it? Very clear? My dear friends, what should be done for mild to moderate cases? Mild cases, not moderate cases. Mild cases, you have to advise them the removal. That's it. So, yeah, you have to advise removal. Okay, nothing additional has to be given to them. But if there is moderate to severe, now any score more than 10 is considered moderate. 8 and 9 would be considered mild, 10 or more would be moderate. So I am writing 8 and 9 as mild, 10 to 14 would be moderate, and 10 to 15 would be moderate, and more than 15 would be severe. Moderate to severe patients, they require combined occipals, yeah, containing anti-androgens, or you may give anti-androgens without combined occipals. If you are giving anti-androgens without the combination of estrogen, then tell them not to become pregnant, because it will have bad effect on pregnancy if they become pregnant. Yeah, combined occipals with anti-androgens or topical application. Yeah, so what are the drugs available with us? You know, there is a drug called drospirenone. Drospirenone is spironolactone derivative. Yeah, drosperinone is spironolactone derivative. It is considered as 4th generation progesterone. Okay. Dose is 3 milligram combined with ethinyl estradiol in combined OC pills. So there are combined OC pills containing drosperinone, ethinyl estradiol of 35 microgram and drosperinone of 3 milligram. There is another drug which is like drosperinone. It is cyproterone. Yeah, it is anti-androgenic again. Yeah, it is also 4th generation progesterone. The dose is 2 milligram. Either this or this with ethinyl estradiol of 35 microgram. Preparations are available in market. Example, Dine 35, Dinate or Ginate. These are the drugs which you so commonly prescribe to your PCOS patients, right? Guys, so yes, these are combined OC pills having 4th generation progesterones. So they will have double action. They will regularize the cycles as well as they will act on the hirsutism part as well. Yeah, guys. Okay, guys, there is a drug called spironolactone. Yes, even this drug can be used. Yes, Dr. Isha has said Yasmin. Yasmin has drosperinone. Cyproterone is there in Dine 35. Ginate also has cyproterone. Dinate has cyproterone. Spironolactone 50 to 100 milligram BD can also be given. This is anti-androgenic. It's a diuretic. It is used as diuretic. Yeah, but it has anti-androgenic property. Males taking spironolactone may develop gynecomastia as well. Yeah, so remember, spironolactone as an anti-androgenic drug can be used. Side effect, since it is diuretic, which is potassium sparing, so hyperkalemia, orthostatic, hypotension may be seen. Regarding drosperinone and cyproterone, the side effects would be fatigue, edema, then mastalgia, loss of libido. Androgens in females have an action on libido. So yes, drosperinone, cyproterone, these are known to cause loss of libido. Priyanka, remember this thing. For the action of anti-androgenic action of these drugs, minimum you have to give treatment for 6 months. Yes, so good question. Minimum treatment is always for 6 months to see any visible effect on the hirsutism. Yeah, it's not like 3 months given and patient coming to you, doctor, nothing has happened. No, you have to give minimum treatment for 6 months. Am I clear about this, guys and girls? There are some other anti-androgenic drugs as well, like finasteride, 5 mg OD. Yeah, it's finasteride, 5-alpha reductase inhibitor. Yeah, there is a drug called flutamide. But it is very hepatotoxic. It's not used, but you should know that this drug is also anti-androgenic. Yeah. Regarding local application, there is a drug called eflornithine. Local application. Yeah, topical application, eflornithine. It is inhibitor of ornithine decarboxylase. Yeah, ornithine decarboxylase. Dr. Rajni has asked, Dine 35 risk of venous thromboembolism. Dr. Rajni, remember any drug containing estrogen. any drug containing estrogen, not only with Di-35, but with any drug containing estrogen, there will be increased risk of venous thromboembolism. And yes, that is why combined OC pills are contraindicated in patients with history of DVT. Combined OC pills are not to be given in a patient who has high risk of hypercoagulable conditions. Yeah, so you don't give these drugs to patients who have hypercoagulable conditions because of estrogenic property. Yeah, estrogen is responsible for DVT, venous thromboembolism. So yes, remember, not to give in patients who have hypercoagulation. Alright guys, are you all with me? Eflornithine, I said eflornithine is inhibitor of ornithine decarboxylase. Dr. Rajni, I hope you understood. Yeah, guys, girls, eflornithine will act on these abnormal hair growth, and because of inhibition of ornithine decarboxylase, the hair growth cycle, there will be arrest of hair growth cycle. Yeah, guys, this is local application. This is not to be taken orally. This is local application. Am I clear about this, guys and girls? So yes, this is all about what we do for patients who have hyperandrogenism. Guys, here I want you people to remember few factual things. Factual thing number 1, serum testosterone normal range in a female is 20 to 18 nanogram per deciliter. More than 150 is seen in androgenic humor. Yeah, this is normal. In PCOS, serum testosterone levels are mildly raised. More than 80 would be there, but not more than 150 for sure. Yeah. Radhika has asked, sir, as the generation of progesterone increases, risk of VT also increases, right? No, in fact, Radhika, let me tell you that, fourth generation progesterones are anti-androgenics. Third generations would be, when they were there in the market for the first time, they were considered as cardioprotective progesterones. Generally, progesterones are not cardioprotective. Yeah. So, you must have heard about desogestrel, gestodine, norgestimate. These are the third generation progesterones. Yeah. They are not as cardioprotective as were thought, but they are much better than others. Yeah. Progesterones are generally not cardioprotective, but these three are better than others. So I would not agree to the point that generation of progesterone increases VTE risk. See, understand, if patient has history of venous thromboembolism, estrogen is the culprit. Okay? Or estrogen is the thing which is avoiding us from giving these OC pills to the patient. Progesterones can be given. Am I clear about this? Yeah. Hina, Talsera, contraception topic, we are going to cover first this list, and then only we can comment about other topics. The list which we had promised you would be covered first, and first and foremost, there are so many things to be covered. Let us go step by step. Don't think about future, think about the topic which is going on. So yes, Radhika, I hope you understood. Estrogen is the component which is causing DVT. In fact, DVT patients, you can give progesterone, but don't give estrogen. Okay, got it? Very clear? Yeah, so I was talking about testosterone. You should remember this range of 20 to 80 nanogram per deciliter. More than 150, you should think about androgenic humor. PCOS mildly raised, but not more than 150 for sure. Yeah. Serum androstenedione. I'll tell you the value of androstenedione is 0.5 to 2.0 nanogram per ml. Not clinically used. Yeah. Serum DHEAS. Cyproterone, Radhika, cyproterone is used in combination. There is no formula preparation available in market where only cyproterone is there. You will not find cyproterone alone. Pharmaceutical companies have not come up with cyproterone alone. But have they come with spironolactone? Yes, they have. Cyproterone is always with combination. Drosterenone is always with combination. with ethynyl estradiol. In US markets, ethynyl estradiol 50 is also there, which is called original diane, DIANE. Yeah, here we have a modified thing called diane 35, which has 35 microgram ethynyl estradiol. Yeah, so hopefully you understand that cyproterone is not in isolation. Okay, serum DHES values are 100 to 350 microgram per deciliter. What is the importance of DHES? DHES value of more than 700 is seen in adrenal tumors. Yeah, am I clear? More than 700 values are seen in adrenal tumors. DHEAS. S is the thing which is produced only by adrenals. Yeah, I'll give you a little bit idea about androgens. If madam has not covered, yes, this would be helpful. I don't know whether madam has covered because it was not in the list. So yes, adrenal glands are there and ovaries are there. Adrenal glands are there, ovaries are there, and there are 4 hormones which I'll write it down over here. First hormone, testosterone. Yeah. Second hormone, androstenedione. You know about androstenedione, I taught you. Theca cells of follicle, 2 cell to gonadotropin theory. LH sits on theca cells and produces androstenedione from cholesterol. You remember? Then there is a hormone called DHEA and there is a hormone called DHEAS. Yeah. Now adrenals produce 100% of all the DHEAs available in body. Yeah. Adrenals are going to produce. Ovaries do not produce DHEAs. Yeah. What about DHEA? Adrenals produce 50% of the whole DHEA in the body. Yeah, 30% comes from DHEAS and remaining 20% comes from ovaries. Yeah, mark my words, 100% DHEAS comes from adrenals. That's why DHEAS is marker of adrenal tumor. If values of more than 700 are found, we think about adrenal tumor. I'll increase the font size. Yeah, I said adrenals are going to produce 100% of the body DHEAs, 50% of the DHEA, 30% comes from DHEAs, conversion of DHEAs to DHEA. Dehydroepiandrostenedione. DHEA is a dehydroepiandrostenedione. Yeah, if you add S to it, that is sulfate. Okay, guys, girls, what about androstenedione? Now here the role is, here 50% from adrenals and 50% from ovaries. Okay, 50% from adrenals, 50% from ovaries would provide the body androstenedione. Okay, great, understood. What about the most important thing, testosterone? Our topic on hirsutism is based on testosterone. And which testosterone? Free testosterone. 1% of the whole testosterone is free. 80% is bound with SHBG. 19% is bound with albumin. Okay. Guys, adrenals are going to produce 25% of the body testosterone. I said adrenals are going to produce 25% of the body testosterone. Again, the system got hanged. Wait a second. Adrenals are going to produce, come on, 25%. Oh, my system, please work properly. Okay, ovaries are going to produce 25%. So the whole testosterone comes from adrenals, testosterone, and the remaining 50% would come from conversion of androstenedione to testosterone in the periphery. Yeah. Fat in the periphery is responsible for conversion of androstenedione to testosterone. Okay. So testosterone comes from periphery as well. Yeah, this story which I have written over here about the hormones in androgenic hormones in females would be covering testosterone, androstenedione, DHEA and DHEAS. Yeah, these figures are important, guys. Why these are important? Because DHEAS values, if they are very high, let's say more than 700, nothing else but adrenal tumors would be your answer. Okay, got it? Very clear, my dear friends. So yes, this is about few facts about the hirsutism part and the treatment modality. What things are going to be done by you? Combined ossiples containing drosperinone or cyproterone. Then I said spironolactone is available as an isolated drug. Finasteride is available, flutamide is available, though it is not used because of hepatotoxicity. Then the local application of eflornithine. Yeah, eflornithine. Generally, skin specialists prescribe all these drugs, but you should know these drugs regarding PCOS. Guys, girls, after you have written about the hirsutism part, let us talk about a related topic to hirsutism, that is alopecia. Give me 1 second. Again, the system got hanged. Today, nakshatra and things are not in proper alignment, I presume. I think this take note or note is heavily loaded. I guess that is why there's an issue. Give me 1 second. Hopefully this doesn't happen again. We were talking about hirsutism. So alright guys, we have covered the hirsutism part and then we are going to talk about alopecia. Okay. So you see these patients in your OPD, they come to you with hair loss. Not many patients come to you with hair loss, but then they may come to you with irregularity of menses and also complaining of hair loss. Alopecia is there. Yeah. So my dear friends, you are supposed to rule out hyperandrogenism in them as well. Yeah, hyperandrogenism, if it is there, then nothing can beat combined ossiples with anti-androgenic for alopecia. But if there is normal androgen level, then you can think about finasteride. So here, when I wrote combined ossipal with anti-androgenic, here the answer would be drosperinone or cyproterone. Here normal androgenic level, you better go for finasteride, which will decrease the dihydrotestosterone levels. Yeah. Minoxidil, 5% solution as local application is also very helpful in them. Yeah. And the final treatment is hair transplant if nothing works out. Okay. Yes, they may suffer from thinning of hair and alopecia. You have to think about hyperandrogenism, rule out hyperandrogenism. If it is there, then combined ossipals containing anti-androgenic progesterone would be the right treatment for them. Normal androgen levels, still there is alopecia, you give them finasteride and minoxidil. Yeah, tell them minoxidil would be a drug which is for local application. Headache is a commonest symptom with minoxidil, and yes, these patients are told not to become pregnant. If they are taking finasteride, they should not become pregnant. Okay, am I clear about this? So nothing great about alopecia, just remember these two things. Okay, next thing, which we will cover in details, but right now we will talk about it in short, is infertility with these patients. I am going to talk about ovulation induction in details for sure. Yeah, but why infertility happens in them? Anovulation. PCOS patients have anovulation, correct? Oocyte quality is hampered. Even if they ovulate, the oocyte quality is hampered. Secondly, endometrial receptivity is also very poor in PCOS patients. So anovulation, direct reason of infertility. Even if they ovulate, the oocyte quality is very poor. That is why it is said that PCOS patients have high risk of abortions as well. Yeah, endometrial receptivity is also affected, obviously because of poor luteal phase function. Ovarian disturbance, having less progesterone levels, can also affect the endometrial receptivity. Yeah, the drug of choice for ovulation induction in PCOS patient has been changed to letrozole. Earlier we used to say clomiphene is the drug of choice. Nothing can beat clomiphene. But now we say letrozole. In fact, this drug was the drug of choice when I was resident in 2007, 2008, 2009. Yes, this was a drug as letrozole. Every patient was given letrozole. But then there was big no from Drug Controller Authority of India, and they said ban letrozole. Letrozole got banned in 2010, I guess. Yeah, and then it came back in the market again. So there is a story of resurgence of letrozole, and even ACOG people have clearly mentioned that letrozole is the drug of choice nowadays. Okay. PG Gynae has asked, laser is permanent treatment. PG Gynae, remember this thing. The plan of action in laser is to damage the root of the follicle, root of the hair follicle. Patient may require 4 to 6 sittings of laser, and then annual maintenance laser is one thing. Yeah, so it is not like laser done once and the patient will be fine. No, laser for hirsutism will require 4 to 6 sittings, and then after that, once new hair growth is stopped, then understand this thing, she will require annual laser. Okay, so yes, damaging the follicle root is very difficult, but if it is there, then it would be success in that area. Okay, so yes, 4 to 6 sittings are needed for laser. Okay, guys, girls, I am right now talking about anovulation. So ovulation induction drug, letrozole is the drug of choice. It is better than clomiphene. We are going to talk about these drugs in details, but remember this thing, letrozole is the drug of choice. Yeah. What about the fourth modality of treatment called insulin sensitizers? We are going to talk about ovulation induction in details in the second part of this session, so don't worry about that. So insulin sensitizers, you know that metformin is the most commonly used drug in PCOS patients. There are other drugs like rosiglitazone, as these are thiazolidinedione. Yeah, then inositols like D-chiroinositol or myoinositol. Yeah, these are insulin sensitizers. Okay, guys, girls, insulin sensitizers, especially metformin, you should know it by heart. Metformin is to be given to PCOS patients. What are the indications of metformin? Indications of metformin therapy. Number 1, impaired glucose tolerance. Number 2, impaired fasting glucose. Number 3, increased HbA1c. Number 4, clear-cut case of diabetes mellitus, type 2 diabetes mellitus. Number 5, any stigmata of insulin resistance like acanthosis nigricans. Acanthosis nigricans. Yeah, guys. Number 6, metabolic syndrome. Now let me tell you few facts about impaired glucose tolerance, impaired fasting levels. Guys, remember, all patients of PCOS should undergo OGTT. Yeah, all patients of PCOS should undergo OGTT. Kajal has asked about dose. Dose of what, Kajal? Please tell me. Dose of what? I will talk about those things. First, let me talk about metformin. I have told you metformin is to be given if there is impaired glucose tolerance, if there is impaired fasting, increased HbA1c, diabetes, clear-cut case of type 2 diabetes, insulin resistance like acanthosis nigricans or biochemical insulin resistance, which I am going to teach you, or metabolic syndrome. Guys, remember, all patients of PCOS should undergo OGTT. 75 gram OGTT. Yeah, we are going to get fasting 1 hour and 2 hour values. Fasting, ideally it should be less than 100, 1 hour should be less than 200 and 2 hour less than 140. Do not get confused between pregnancy diabetes and this. This patient is PCOS, she is not a GDM patient. These values are not for GDM patients. I am talking about a PCOS patient who is not pregnant. Okay, this value, this is ideal level of fasting, 1 hour, 2 hour. Okay, what about a patient whose value is between 100 to 125? Yeah, 100 to 125. This patient is considered as a case of impaired fasting glucose. 100 to 125 is impaired fasting glucose. Acha, you are talking about metformin. I will talk about it. First, listen to this. Listen to this. Fasting 100 to 125 is impaired fasting glucose. If it is 126 or more, she is a clear-cut case of diabetes mellitus. Yeah, clear-cut case of diabetes mellitus. If fasting insulin level is more than 20 milli international unit per ml, it is called insulin resistance. Yeah, I have told you about 75 gram OGTT where blood glucose levels are to be taken care of. Consideration is to be given to blood glucose levels. If fasting is less than 100, congratulations. 100 to 125, impaired fasting glucose. 126 or more, clear-cut case of diabetes. Yeah, guys, 1 hour value should be less than 200. If 2 hour value is to be taken, then less than 140. If value of 140 to 199 you get, that is called as impaired glucose tolerance. Impaired glucose tolerance. Am I clear? When the value is 200 or more, then we say a clear-cut case of diabetes is there. This is impaired glucose tolerance, and 200 or more would be diabetes mellitus. What about what about insulin levels? Insulin levels at the end of 2 hours, if more than 55 international unit or milli international unit per ml, that is also insulin resistance. Yeah, more than 55 milli international unit. Here what was the value? More than 20 milli international unit per ml is insulin resistance. Yeah, fasting value of insulin more than 20 milli international unit per ml is insulin resistance, and insulin at 2 hours more than 55 milli international unit per ml is insulin resistance. If the value you get as insulin levels of more than 100 milli international unit per ml, we say it is severe insulin resistance. Severity. Yeah, more than 100. Anything more than 55 at the end of 2 hours, insulin levels, then you are dealing with insulin resistance. Am I clear about this, guys and girls? Regarding insulin levels, you have understood this thing. What about 1 hour value? 1 hour value, remember this thing, is about fasting. A 1 hour glucose level less than 200 is normal. 200 or more is abnormal, it is impaired glucose levels. Yeah, insulin resistance is defined as more than or equal to 80. Okay, severe insulin levels, severe resistance would be more than or equal to 300. This is about insulin resistance at 1 hour. Any one value is sufficient to label someone as a case of insulin resistance. I repeat, listen carefully. All patients who have PCOS should undergo oral glucose tolerance test. As simple as that. Yeah. If you want to know about their insulin resistance as well, if you want to know about their impaired glucose tolerance, then you should do oral glucose tolerance test. So listen to the values. Fasting, normal value less than 100, 1 hour value less than 200, 2 hour value less than 140. If fasting value is 100 to 125, it is impaired fasting glucose condition. Yeah. If it is 126 milligram per deciliter of glucose, then you are dealing with a case of diabetes mellitus, nothing else. You remember in our overt diabetes mellitus topic, I discussed fasting 126 or more, or 2 hour, that is postprandial blood sugar of 200 or more is diabetes mellitus, overt diabetes mellitus. Here also same thing. Yeah, fasting 126 or more or 2 hour 200 or more, you are dealing with diabetes mellitus. Regarding insulin resistance, the most commonly used method for insulin resistance is fasting insulin and 2 hour insulin levels. Fasting insulin level of more than 20, 2 hour insulin level of more than 55 is considered as insulin resistance. Am I clear? Guys, girls, so yes, is there any role of ratio of fasting glucose and fasting insulin? That is also there. That is also there. Remember, fasting glucose upon fasting insulin less than 4.5 is normal. 4.5 or more is a clear-cut case of insulin resistance. Am I clear about this, guys and girls? Yes, so this ratio is more specific for diagnosing insulin resistance. Why are we doing all these things? We want to decide whether metformin has to be given or not. What are the indications of metformin? A. Impaired glucose tolerance. Impaired fasting glucose. What do I mean by impaired fasting glucose? Fasting level of 100 to 125. What do I mean by impaired glucose tolerance? 2 hour value of 140 to 199. What about diabetes mellitus? If fasting is 126 or more, 2 hour 200 or more, you are dealing with diabetes. Or you are getting clinical findings of insulin resistance, that is acanthosis nigricans. You know, there is one very famous syndrome, hyperandrogenism, insulin resistance and acanthosis nigricans, hair and syndrome. Yeah. Hansween has asked, sir, fasting of 8 hours like in OGTT? Yes, of course. Guys, these values are important in determining whether there is insulin resistance or not. But are these values are only values which are used for determining insulin resistance? I will say no. There are many studies done. Somebody has asked me about, Shairi has asked HOMA index. There are many other studies available which tell us about insulin resistance. What Shairi has asked is about HOMA index. That is also one way of diagnosing insulin resistance. Yeah, HOMA is not HOMA, it is HOMA IR, full formed as homeostasis static model assessment of insulin resistance. Homeostatic model assessment of insulin resistance. This is one of the study. Yeah, though it is not clinically. In your hospital, you will not do HOMA index. Yeah, we will do fasting glucose, we will do fasting insulin level. Very rarely you go for this, right? So what is there in this HOMA index? Glucose levels in milligram per deciliter multiplied by insulin levels in milli international unit per milliliter, divide by 405. Yeah, if the value is more than 3.2, then we say this is insulin resistance. Yeah, this is HOMA index, HOMA IR, homeostatic model assessment of insulin resistance. There is one more, that is, I hope you have written this, guys. There is one more for insulin resistance assessment. There are many actually studies, there are so many studies available. There is something called Quickie. This is also one way. Do we do it in clinical practice? No, not at all. It is full formed as quantitative insulin sensitivity check index. Yeah, there is a formula of Quickie: 1 divided by log of glucose levels plus log of insulin levels. So logarithmic tables are used for doing this index. Yeah, logarithmic of glucose levels, log of insulin levels. If the value is more than 0.33, that is insulin resistance. So all in all, remember, we are going to think about fasting glucose and fasting insulin level in our clinical practice. HOMA and Quickie are only for your theory purpose. Yeah. In HOMA, these are fasting levels. Shairi, both are fasting levels. HOMA index is basically about fasting. Yeah, it's not about any random glucose or insulin level. These are fasting levels. Okay, F glucose, F insulin. Okay, here also F glucose, F insulin. Okay, all right, guys, girls. So there are many ways, but we are going to stick to our ratio called fasting glucose upon fasting insulin. Less than 4.5 is normal. More than 4.5, more than or equal to 4.5 is insulin resistance. Am I clear about this? Now comes the question about how to go about these patients who indeed have insulin resistance. You are supposed to give them metformin. Metformin is very good drug. Yeah, metformin is to be given. Remember, always go slow with metformin. Yeah, you can start with even 250 milligram as the lowest dose. Maximum 1.5 gram can be given in divided doses. Yeah, so you can give metformin. If patient is on metformin therapy, then she should continue this in pregnancy if she becomes pregnant. Okay, Metformin therapy is going on. She becomes pregnant on metformin therapy. Tell her to continue metformin, because yes, metformin is said to be preventive for development of GDM as well. Yeah, that's true. And secondly, metformin therapy will help in maintenance of insulin sensitivity, which is essential in PCOS patients. Okay. Yeah, guys and girls, metformin therapy decreases risk of OHSS if gonadotropins are given. If gonadotropin therapies are given for doing ovulation induction, then metformin therapy is very useful in reduction of OHSS. Yeah. PG Gynae has asked 1 hour value. 1 hour, I told you, 200. It should be less than 200. And yes, I said insulin levels should be less than 80. Insulin levels should be less than 80 at 1 hour. Okay. If it is 80 or more, then we say insulin resistance is there. If it is more than 300, then you are dealing with severe insulin resistance. PG Gynae, I hope you understood this. Shairi, I hope you understood this. I have talked about the definition of insulin resistance with different indices, and I told you metformin values. Metformin 250 milligram is the lowest dose. Yes, sustained release metformin, their preparation, Glycomet is available in market. Sustained release metformin reduces risk of nausea, vomiting. So GI upsets are less with sustained release tablets. Am I clear, guys, girls? If patient is not taking metformin because she is not an indication of metformin therapy and she becomes pregnant, do not start metformin in pregnancy. Yeah. If patient is taking metformin, her indication was there, she was on metformin, please continue metformin therapy. Am I clear about this? Yeah, guys, girls. So yes, this is about the metformin therapy. This is about the fourth element of the treatment modality. Let us summarize. First thing I talked about was lifestyle modification. Then I talked about menstrual disturbances. Then I talked about hirsutism and alopecia. Then I talked about infertility. Yeah, then I talked about, yes, ovulation induction drug, which I did not talk in details. I will cover that in our next topic. But then I talked about the metformin, insulin sensitizers. What about long-term effects? Of PCOS. You know that insulin resistance is the basic problem in PCOS patient, in most of the PCOS patient, and insulin resistance would increase the insulin requirement. So beta cells will go into hyperactive mode. They will produce more insulin. So ultimately there will be decreased beta cell reserve in future. And ultimately there will be diabetes mellitus in future. Yeah, any PCOS patient should undergo 2 yearly OGTT. But if PCOS patient has impaired glucose tolerance or impaired fasting glucose, then 1 yearly OGTT is needed. Why? Because they have high risk of developing diabetes in future. So you have to be the first person to know that this patient has developed diabetes. So you have to tell PCOS patients to undergo 2 yearly OGTT. Okay, there is increased risk of CVS disease. Rajni, you have asked about a very good question. Metformin, can it be used as ovulation induction drug alone? There are studies where clomiphene is compared with metformin. There are studies where clomiphene is compared with metformin with clomiphene plus metformin. Believe me, clomiphene plus metformin and clomiphene, they are the winners. Isolated metformin treatment is not the best ovulation induction protocol. Though it is there, but the outcome of metformin alone as ovulation induction is not great. Live baby rates are less in metformin alone. So ovulation induction has to be done with, anti-estrogen, what is called as clomiphene or letrozole as the drug of choice nowadays. Dr. Isha has asked this question, sir, if patient has PCOS with irregular cycles and has infertility also. See, understand, when patient has irregular cycles and infertility, don't you think that treating infertility will give pregnancy to her, and pregnancy will be progesteronic effect, and that may itself solve the issue of PCOS, at least temporarily. So we give importance to infertility, we will give ovulation induction management. We will not give combined ociples to a patient who has PCOS with history of infertility. I mean, she is anxious to conceive, she desires to conceive, then you don't give combined ociples for obvious reasons. Okay, am I clear? Right now I am teaching you the long-term effect. I told you diabetes and what to do in management protocol. You have to do 2 hourly OGTT, 1 hourly OGTT if there is impaired glucose levels. Yeah, got it? Guys, serious disease. Why? Because PCOS is nowadays considered as inflammatory condition. Yes, it is true. PCOS is no longer limited to ovaries nowadays. It is inflammatory condition. The inflammatory markers like C-reactive proteins are increased. Interleukin 6 is increased. C-reactive protein, interleukin 6. WBC count may also be raised in some cases, not all. Yeah. So PCOS has increased risk of CVS disease by 4 to 7 folds. CVS, yes, PCOS patients have increased risk of 4 to 7 fold. On top of it, there is hyperandrogenism and obesity. Believe me, 50% PCOS patients are obese. So obesity is also there. So there would be dyslipidemia, which would add to the CVS disease risk. Yeah. So guys and girls, dyslipidemia, which means HDL cholesterol would be less, LDL cholesterol and triglycerides would be increased. So these patients have increased risk of CVS disease. On top of it, there is something called metabolic syndrome. Famously called as Syndrome X in past. Nikunj has asked this question, sir, why don't we follow PCOS patients with fasting blood sugar than OGTT? Nikunj, I told you indication of metformin. If fasting value is normal, let's say fasting is 93, but postprandial value is let's say 186. Is it impaired glucose tolerance? Yes, it is. Did fasting tell you this? No. Fasting value can only tell you impaired fasting glucose. Yeah. Impaired glucose tolerance is always 2 hours later you will see the levels of glucose. If it is less than 140, congratulations. But if it is 140 to 199, you are dealing with impaired glucose tolerance and you should give them metformin therapy. Yeah. So yes, we want to know whether metformin, that drug which is insulin sensitizer, should be given to them or not. There is metabolic syndrome which will increase the CVS risk. Metabolic syndrome. Increased waist circumference. What we say as central obesity is a very, very important factor of metabolic syndrome. Yeah. How much? More than 85 centimeter in females is important marker of metabolic syndrome. Secondly, blood pressure is increased more than 130 by 85. Yeah. Thirdly, triglycerides are increased more than or equal to 150 milligram per deciliter. Yeah. Then HDL cholesterol is decreased less than 50 milligram per deciliter. 50 milligram per deciliter. So there is dyslipidemia. Dr. Isha has asked this question, sir, if the patient has hyperandrogenism and insulin resistance also, we will treat her first, after that we will give ovulation induction. Of course, yes. It is said that clomiphene therapy or letrozole therapy would work wonderfully well if there is inhibition of androgen excess initially. Yeah. Let me come to ovulation induction topic, and that topic is so wonderful, so clinically important topic. I'll cover all these things which you are asking me. Right now, I'm talking about long-term effects, and yes, metabolic syndrome is one very important long-term effect. How to know whether she has metabolic syndrome? BP would be raised, waist circumference raised, dyslipidemia would be there, yeah, increased fasting glucose. So diabetes, obesity, hypertension with dyslipidemia, these all things form metabolic syndrome, and the drug of choice, treatment of choice for these patients is none other than metformin. Yeah, 1500 to 2000 milligram per day. Yeah, we are not dealing with PCOS alone. We are now dealing with a metabolic syndrome. The dose is 1500 to 2000 per day. Again, the rule is start low. Hansween, in Indian women, yes, I agree that the values are less, but tell me one study which has told me about Indian women. This figure called 85 is about American females. I agree to that. Indian females, the values are not defined well, but then that figure of 80, what you have said, is there in one study, but that is not a very big study. So yes, what you are telling me about Indian females having values of less than 80 as normal, 80 or more as abnormal is agreed. I agree to that. In fact, do you know that overweight patient is defined as BMI more than 25 all over the world except in developing countries, example India, where overweight patient is more than 23 BMI. So yes, the values are different, but Indian values are not given in standard textbooks like Spirov, like Novak Gynecology. So I can't tell you about that figure as 80 centimeter. I will tell you what is there in standard textbook, and that is 85 centimeter. Okay, Ansween? Yes, you are right. I don't disagree to your point that Indian female value would be less. Overweight and obesity definition is also less different in Asian population. Okay, so you are right. All right, let me come back to treatment of metabolic syndrome, and yes, how to reduce the risk of cardiovascular disease in future. Metformin. Metformin is the drug, 1500 to 2000 milligram per day. You have to start low. Metformin is known to decrease vitamin B12 absorption. So watch out for vitamin B12 deficiency symptoms like peripheral neuropathy, tingling, numbness. Yeah, I have written PN, peripheral neuropathy symptoms like tingling, numbness. Yeah. So my dear friends, yes, metformin is the drug which has to be given. Metformin is contraindicated in renal disease or liver disease. Yeah. Hansween has given some smiley of this one, question mark. Okay. How metformin dose is increased? Sequence of increment. See, we always start low. 250 milligram BD is what is started. Then you do 500 milligram BD. And if you are talking about sustained release, then 500 milligram BD may be sufficient in most patients. Okay, guys. But then you have to titrate the dose. You have to then you have to increase the dose, not titrate. You have to increase the dose, and the maximum value which is needed is 1500 to 2000 milligram per day. Yeah, start with 250 BD. Yeah, in your hospitals, glycomet tablets 500, sustained release tablets are there, 500 BD. That is also okay. I can't say the lowest value as 250 because it is all dependent on patients' nausea, vomiting, and GI symptoms. If you are asking me personally, I give glycomet SR 500 BD. That is what my treatment protocol is there. Glycomet SR 500 BD, that's it. and that is what is given to PCOS patients. You're talking about metabolic syndrome. Patients who have metabolic syndrome generally do not come to gynec OPD first. But let me tell you, if they come to gynec OPD, I would not give them 500 BD. I will have to increase the dose, probably 500 QID. Yeah. So yes, that's the protocol. Okay. Yeah. I was talking about metformin contraindicated in renal disease, liver disease, and if patient is a patient with chronic alcoholism. Yeah. So these are the contraindications for metformin therapy. Am I clear? Guys and girls, after you have done this, other drugs in metabolic syndrome. Other drugs in metabolic syndrome, I said thioglitazones. So rosiglitazone, pioglitazone, not thio, pioglitazones. Yeah, these are the drugs which can be used. These are agonists for peroxisome proliferator activator receptor gamma. Unfortunately, you will have to remember this, PPAR gamma. These are agonists for PPAR gamma. Hina is asked about 250 milligram BD up to what time then increased. See, when they have tolerated 250 milligram BD, then you can increase to 500 milligram BD. So tolerate, whether they are tolerated or not can be understood in 3 days. So yes, 3 days later on you can make it 500 BD. Okay, am I clear? If you are talking about a syndrome X patient, then you have to make it 500 QID. Okay. How long to give metformin? Again, Radhika, understand that our main aim of these patients is to prevent diabetes in future. And yes, I told you, if they are on metformin and they become pregnant, then you have to understand that this metformin has to be continued in pregnancy. Okay, got it? So yes, metformin has to be continued in pregnancy if patient is already on metformin. What about, sir, since for how long she has to continue this? Try to understand this logic that PCOS is a disease of abnormal lifestyle. If lifestyle modification is successful and she has successfully brought down insulin resistance, then we may wean off from metformin. Let me tell you, PCOS patients, they find it really very hard to lose weight because their metabolism is really very bad. So yes, if they can bring about lifestyle modification and weight reduction, their dosage requirement would be reduced. Okay, got it? So yes, ideally these patients should be off medicines. They should have good lifestyle and their weight should be under control. Their BMI should be under control. And for achieving that, they should have lifestyle modification. Okay, guys, Radhika, I hope you understood this. Give me 1 second. Yeah. So yes, this is about metformin. Right now I'm teaching you about the other drugs in metabolic syndrome. So I said rosiglitazone, pioglitazone, these are the drugs. Agonists for PPARG. Yeah, peroxisome proliferator activator receptor gamma. You have to remember this. In simple word, this is a gene regulator agonist. It's agonist for gene regulator. The glitazones are agonists for gene regulator, PPAR. Okay, guys, girls, these drugs are known to improve insulin sensitivity by acting on the genetic level. Okay, so yes, one more thing, these are not recommended in patients desiring pregnancy. Very, very unsafe drugs in pregnancy. These drugs are not to be given in patients desiring pregnancy. Am I clear? I am teaching you metabolic syndrome. I told you metformin is the drug of choice. Rosiglitazone, pioglitazones can be used. The newer drugs which are available, newer drug which is available is called as incretin. incretin. Yeah, again, metabolic modulators. Metabolic modulators. What do? They decrease gastric emptying. Yeah, they decrease glucagon secretion. Yeah, so these are metabolic modulators. These are, or this is, actually there are two types, I'll tell you. Decrease gastric emptying, decrease glucagon secretion, increase insulin secretion, increase insulin signaling. Yeah, and appetite suppression. So they act by metabolic modulation. All these things which I have written on the list would ultimately help in reducing the weight, and yes, they will help in improving the insulin sensitivity. Yeah, guys, so there are two types of incretins: GLP-1 receptor analogs, yeah, and one is DDP4, dipeptidyl peptidase 4 inhibitor. What you need to remember are the drugs used in metabolic syndrome like metformin, glitazons, incretin. That's it, nothing else. Yeah, guys, if there is a patient who has dyslipidemia, by dyslipidemia you know triglyceride more than 150, HDL cholesterol less than 50, the drug of choice would be statins. Simvastatin or atorvastatin are the drugs used. 20 milligram OD. 20 milligram OD is the dose of statins used in dyslipidemia. The good thing about statins would be they would decrease testosterone. Yes, that's true. Statins would decrease testosterone. They would decrease the CRPs, C-reactive protein, so inflammation is reduced. Insulin resistance is decreased, and they will improve the lipid profile. Yeah, you know that statins are HMG-CoA inhibitors. Yeah, HMG-CoA reductase inhibitors. So there is one cholesterol pathway, yeah, mevalonate pathway. Just remember this thing, the HMG-CoA reductase inhibitors, statins, are useful in dyslipidemia. They help in reducing the testosterone levels, CRP levels. They improve the insulin resistance. They improve the insulin sensitivity, and they improve the lipid profile. Okay, but these are contraindicated in pregnancy. They are known teratogenics. Yeah, so these are contraindicated drugs in pregnancy. These drugs are known teratogenics. Am I clear about this, guys and girls? So my dear friends, right now we have done PCOS. I talked about management, I talked about lifestyle modification, I talked about the hirsutism part, then I talked about abnormal menstrual cycles, then I talked about alopecia, then infertility part is going to be covered in next part of the session, and then I talked about long-term effects and the management. Guys, girls, we'll take a 5-minute break, and then we'll come back with the next part of the session called as ovulation induction. Right now it is 7:18 p.m. We will start next session. Okay. Yeah. Any question? Question? Yeah. Okay, I'll scroll up. I said dyslipidemia, you have to give statins. I said metabolic syndrome, you have to give metformin, pioglitazone, rosiglitazone, and incretins are the new drugs which are available in market. Okay, so take a 5-minute break and we will be back. Alright guys, welcome back for the next part of this session. And yes, we are going to talk about ovulation induction in details now. Guys and girls, now this topic called ovulation induction would not only cover PCOS, but it will also cover other cases of anovulatory disorders. Yeah. So yes, be ready. This topic you may write it separately if you want, but then yes, you know that this topic is a part of infertility management as well. And sphere of chapter is dedicated to this topic. So yes, let us talk about this topic called as ovulation induction. First, very basic things which you have learnt in your MBBS days, that yes, most common cause of infertility in females is anovulation. Yeah, 18 to 25% of infertile females have anovulation, so ovulatory disorder. 18 to 25%, which is a big number. So if you understand ovulation induction well, you are probably taking care of 1/4 of the infertility chapter as well. So it's an important topic. So how do we diagnose that a patient has ovulation anovulatory disorder? So if patient has history of irregular menses which are unpredictable, infrequent, then this itself is a very important giveaway that she might be having anovulatory disorder. Yeah guys, not always, but remember this thing, that irregular menses would be a clear-cut marker of anovulatory disorder. Okay, not in all cases, but remember, even regular cycles can be anovulatory. Yeah, every time 28-day cycle can also be anovulatory. So remember, ovarian cycle and endometrial cycle, even though they are connected, but there are few cases where anovulatory cycles may have normal endometrial cycle. Okay, so yes, we should know whether patient is ovulating well or not. So there are many methods which you have learned in your MBBS days, like basal body temperature method. Yeah, you remember your good old days. Believe me, this method is only for your theory purpose. Practically, we don't use this. You know that normal body temperature is increased by 0.5 degree Fahrenheit because of progesterone. So if there is rise in the body temperature by 0.5 degree Fahrenheit, then surely the patient has ovulation. Okay. So yes, if there is a uniphasic pattern, see, normal is biphasic, basal body temperature. If there is uniphasic, that means no increase in body temperature, then it is a marker of anovulation. Okay, guys, girls, it is not clinically used because we have wonderful methods available to understand whether patient has ovulated or not. Very simple. In fact, simplest of them all is serum progesterone levels. It's very simple, simplest, most commonly used. Yeah, you may argue with me, sir, in our hospitals we do transvaginal sonography for folliculometry to understand whether patient is ovulating or not. But then believe me, doing transvaginal scan every alternate day or every day is very invasive kind of procedure for knowing whether she has ovulated or not. So yes, It's not necessary nowadays to do TVS for knowing for knowing ovulation induction, for knowing anovulatory disorder. Serum progesterone is the simplest way. I am right now talking about diagnosis. I am not talking about IVF cycle or clomiphene cycle, where transvaginal sonography has its own importance. Right now I am teaching you about diagnosis. Serum progesterone level is for diagnosis. Yeah, less than 3 nanogram per ml on day 21, 22 of 28 day cycle is a marker of anovulation. But who knows that patient has day 21 of her cycle, or whether patient has a 35 day cycle or 28 day cycle this time. We do not know. It's always a retrospective thing. She menstruated on day 28, that's why day 21 would be, the day when progesterone would be highest. So understand this thing. Serum progesterone levels 1 week before expected menses, less than 3 nanogram per ml is a marker of anovulation. More than 10 nanogram per ml surely means she has ovulated. That doesn't mean less than 10 means anovulatory. Yeah, less than 10 may be seen in normal patients, may be seen in a condition called luteal phase defect, but remember, anything more than 3, she has at least ovulated. Yeah, less than 3, anovulatory. 3 to 10 is a gray zone where patient may or may not have ovulated. Okay, yeah. So take home message, less than 3 is anovulation. Guys, girls, nowadays, in market, there is a brand name, I am writing brand name, forgive me for that, I know kit or LH kits or ovulation kits. These are fancy names given to those kits which are available in market. The pharmacy shops have these kits, and the patients will do their urine test at home, and they will get to know the best time for ovulation, and then they may time the intercourse at that time. Yeah, so LH kits, home kits are available. They detect urinary LH. Yeah, so LH surge may give positive LH kit line, like control and test. Yeah, just like pregnancy test kit, these kits are available, and yes, they are to be done from day 11 every day. Once patient has had LH surge, that means 2 lines are seen, we say that patient is going to ovulate the next day or within 36 to 48 hours. Yeah, so yes, guys and girls, LH kits are there. Even TVS, transvaginal sonography, is also test for ovulation. If you want to do assessment of follicle growth, if you want to do clomiphene cycle, if you want to do gonadotropin cycle, you should know the follicular size, because there is a risk of ovarian hyperstimulation syndrome. So TVS has its own place in ovulation induction management. But understand this thing, whether she is an ovulatory patient or not, TVS is not the best for diagnosis of an ovulation. Yeah, am I clear? It's not the best for diagnosis. Is it good for assessment of follicular growth and effect of clomiphene or letrozole or gonadotropin? Yes, it is very good. Yeah, for monitoring purpose, it's very good. But for diagnosis purpose, I would say no. Yeah, folliculometry, that's the famous name given to it. Transvaginal sonography, folliculometry. Okay, so yes, there are many methods of knowing whether she is anovulatory or not. Serum progesterone level is very simple, cheap, effective method of knowing whether the patient is anovulatory or not. Let's talk about classification of ovulatory disorders. Let me tell you, WHO has given 3 classes, but actually the 4th class is also there. So what is class 1 or group 1, you can say? Let me write group 1 only. I will not write class 1. Group 1 patients are those patients. Give me 1 second. Yeah, group 1 patients are those patients who are labeled as hypogonadotropic, hypogonadism. Yeah, you remember our primary amenorrhea topic also had these groups. Yeah, so hypogonadotropic, hypogonadism, and believe me, 5 to 10% of all the patients having ovulatory disorders will be group 1 patients. How do you know group 1 patients? How do you label group 1 patients? FSH would be low in them, estradiol would be low in them, GnRH would be low in them. Yeah, FSH low, estradiol low, GnRH may be low. These 2 are most important. FSH low, estradiol low. Examples like eating disorders, like anorexia nervosa, bulimia nervosa. Yeah, physical, nutritional, emotional, stress. So stress of physical kind, nutritional kind or emotional kind can inhibit GnRH. Yeah, excessive weight loss. Yeah, Kalman syndrome. You know, Cal1 gene mutation, so anosmia, and there is GnRH cell deficiency. Yeah, color blindness may or may not be there. Idiopathic hypogonadotropic hypogonadism, written as IHH. All these conditions are falling in group 1. Group 1 patients are those patients who do not have gonadotropins in order to start the ovarian cycle, as simple as that. Yeah, either the problem is in the hypothalamus or the problem is in pituitary. That is why ovarian cycles do not start, and that is why anovulation is there. Yeah, so these are group 1 patients. This classification is very important, guys, so please be attentive. Group 2 patients are the most common types of ovulatory disorders. These are normogonadotropic, normoestrogenism. Yeah, 75 to 85% patients having ovulatory dysfunction would fall under group 2. The FSH values may be normal or low normal. Estrogen levels normal. LH is increased. Why they are called normogonadotropic, normogonadism? Because a normal FSH, normal estrogen levels are there. LH increased. Don't you think these patients are PCOS patients? PCOS is most common ovulatory dysfunction present. Okay, so this is considered as group 2. PCOS patients, normogonadotropic, normoestrogenism. Then would be group 3. Group 3 patients are those patients with ovarian failure. So hypergonadotropic, hypogonadism. In simpler words, ovarian failure. We have covered this, madam had covered this in our secondary amenorrhea topic, ovarian failure patients. 10 to 20% patients would fall under this group 3 category. Hypergonadotropic, hypogonadism, so ovarian failure. Okay, where FSH would be very high. Yeah, AMH would be very low, so ovarian reserves are very low. Okay, they might be suffering from amenorrhea. Yeah, premature ovarian failure, secondary amenorrhea is seen. Yeah, these are those patients, premature ovarian failure patient. This is what is given by WHO, group 1, group 2, group 3, but there is group 4 also, not in WHO categorization. This is hyperprolactinemic anovulation. Hyperprolactinemic anovulation. So those patients having disorders of prolactin excess. Prolactin, as you know, inhibits GnRH. So FSH is low or normal, low normal. Yeah, estrogen levels are low. So it acts on GnRH, that is why GnRH gets inhibited. So obviously gonadotropin and estrogen levels would be low. They may come with oligomenorrhea or amenorrhea. Yeah, oligomenorrhea or amenorrhea. Roughly 5% to 10% patients have hyperprolactinemic anovulation. Okay, guys, girls, why has everyone become silent suddenly? No question asked. Acha, Ayushi has written, please scroll up. Okay, fine. I said group 1. What was group 1 case? Hypogonadotropic, hypogonadism. Example, hypothalamic or pituitary dysfunction. So eating disorder, stress, excessive weight loss, even athletic exercise can cause amenorrhea. You know that they have GnRH inhibition, and that is why there will be amenorrhea, and yes, obviously there will be anovulation as well. Kallmann syndrome, Kallmann gene mutation is there. Idiopathic hypogonadotropic hypogonadism. These are group 1 patients. Group 2 would be PCOS patients. Yeah, normogonadotropic, normoestrogenism. Group 3 patients are hypergonadotropic hypogonadism. These are ovarian failure cases. FSH is high. AMH, anti-Mullerian hormone, which is marker of ovulation reserve, ovarian reserve. Yeah, AMH is low. Amenorrhea would be there. Group 3 patients. Yeah, guys, why suddenly everyone has become silent? I feel that my mobile is not working or something like that. Guys, cheer up. No chats available. What happened? Yeah, group 4, as simple as hyperprolactinemia. That's it. WHO classification is only group 1, group 2, group 3. Group 4 is hyperprolactinemia. Okay, taking notes. Good. Right. So, my dear friends, I hope you people are enjoying the session. I hope you people are actively writing notes. Ayushi has asked about first page after the break. Okay, let them finish off this group 1, 2, 3, 4, and then I will show that first page. See, I talked about ovulation induction. Then I gave some figures regarding the magnitude of the disease, 18 to 25%. And then I talked about diagnosis, serum progesterone level, simplest, cheapest, easiest, most commonly done for diagnosis. Yeah, BBD method, then INO kit, what is called an LH kits. Even endometrial biopsy for that matter can be used for diagnosis. But is it used for diagnosis of anovulation? Not really. It is used for many other things, but not for diagnosis of anovulation. Yeah, theory wise you can use cervical mucus method as well, but don't you think cervical mucus assessment will not be done by patient? Our so called even educated patients cannot assess cervical mucus and correctly diagnose whether they have ovulated or not. So forget about our class patients who come to our OPD. Okay, so yes, we have to rely on something very strong, and that is serum progesterone levels. Alright guys, now you have understood how to diagnose, then you understood the classification of ovulatory disorders, group 1, group 2, group 3 and the group 4. Yeah, then I want you people to write down evaluation. Yeah. Radhika has asked, sir, in athletes, how GnRH is affected? Radhika, try to understand this way that athletes who are involved in rigorous exercise, whatever you say, the body says, I am not ready for pregnancy. Whenever there's kind of stress, even exercise in severe form is a kind of stress to the body. And whenever there is stress to the body, there is release of, endorphins or dynorphins. They have negative effect on GnRH. Yeah. Understand this thing. It's a body's mechanism of telling that I am not ready for pregnancy. By inhibiting GnRH, body is inhibiting pituitary, and by pituitary inhibition, ovarian inhibition, and then obviously pregnancy won't happen. So for pregnancy to happen, healthy body, sound body, stress-free body is necessary. Athletic exercise, athletes have amenorrhea who are in vigorous exercise, especially gymnasts. Those patients have amenorrhea. Their body habitus, their eating habitus, and their vigorous exercise habitus will all affect the GnRH. So there is obviously an effect on GnRH production, and that would lead to amenorrhea and obviously anovulation as well. Okay. Hina, maturation index, yes. Even the vaginal cytology can tell you whether patient has ovulated or not. Superficial cells are estrogenic cells and intermediate cells are progesteronic cells. So if I say that there are intermediate cells in abundance, then patient has ovulated. There is something called maturation index. Superficial cells of vagina are considered as estrogenic cells, and intermediate cells are considered as progesteronic cells. Do we do all these things in our OPD? No, we don't. You ask yourself. If an infertile patient comes to your OPD, do you take vaginal cytology and send to cytologist to tell you whether patient has ovulated or not? This is all about theory. We do serum progesterone levels, yeah, and we also do folliculometry. Why should I lie to you? Folliculometry is done because we need a baseline sonography as well. So yes, we do folliculometry, but then yes, it's not the best of them all for diagnosis. Okay. All right. Yeah. So let's talk about evaluation. I am holding my mobile in one hand like this, so sorry for that weird situation and position. So yes, I am trying to get your questions over there. So evaluation. Try to understand that you have to know the cause. And to help you out, you have figured 75% of ovulation disorders would be PCOS patients. And PCOS is diagnosed, you have learned PCOS now. PCOS is diagnosed by Rotterdam's criteria, AEPCOS criteria. Yeah. So to know the cause, knowing the cause is important. Don't you think only PCOS is not there? So there are so many other conditions which may affect ovulation. So thyroid, prolactin, adrenal cause, pituitary cause, ovarian tumor, eating disorders, or even PCOS have their specific histories. Yeah. So hypothyroidism may have cold intolerance. Prolactin patients, excess patients will have galactorrhea. Adrenal cause, there will be hirsutism, and testosterone levels would be more than 150 nanogram per deciliter. Pituitary cause, there is something called bitemporal hemianopia. We covered that in our pituitary topic. Yeah. Ovarian tumor, again, they may be estrogenic or androgenic. Eating disorders, PCOS, these all things can be evaluated by history. Yeah, Hina, you are right. In theory exam, you have to enlist for sure. You want to hear the list of tests of ovulation? Then yes, A would be, as I told you, basal body temperature method. B would be billing method, what is called as cervical mucus method. If it is stretchable mucus, that is estrogenic. If there is loss of stretchability, that is progesteronic. There is something called Ferning test of cervical mucus. So there is stretchability test, there is a Ferning test for cervical mucus. Yes, there is one scoring system as well, Insler score, which takes care of stretchability, called as Spinner-Barkit and Ferning in microscopy. Then there is vaginal cytology test. Then there is something called as, obviously, serum progesterone levels, endometrial biopsy premenstrually. Then for detection of ovulation, folliculometry is also there. So I have told you the whole list. Okay. Right now I am teaching you evaluation. I have told you what things are to be asked: thyroid, prolactin, adrenal cause, pituitary cause, ovarian tumor, eating disorder, PCOS. All will have their histories. I will not go into the details of them, but try to pick up these things in history if patient is a case of anovulatory. Yeah, guys, girls, you have to take their weight, their height, their BMI. Yeah, BMI is must. Why? Because obviously PCOS patients with high BMI, PCOS patient may have high BMI, or obesity itself may cause androgen excess. So yes, you have to know about BMI. Weight, height, BMI is to be calculated. Weight upon height cube. Sorry, weight upon height square. Weight upon height square, not cube. Okay, guys, weight is in kilogram, height is in centimeter. Sorry, weight is in kilogram, I was disturbed. Height is in meters. Okay, yeah, not centimeter, meters, height square. Yeah, kg per meter square, correct. So BMI is to be calculated. Then after that, patient has come to you with a case of infertility, right? So semen analysis is must for all infertile couples. I am writing couples because infertility is not only the disorder in females. You have to take care of this as a couple infertility. So semen analysis is must. Yeah, guys, try to understand that glycemic status, that means OGTT, is must in all PCOS patients. At the cost of sounding repetitive, I am writing this statement because this is very important statement. Patients who have PCOS, you should do OGTT, because you need to know whether metformin has to be given or not, right? And then in non-PCOS patients, you have to do OGTT if there is family history of diabetes. Yeah, if BMI is more than 25, you should do OGTT. Yeah, if there is impaired value in past, you should do OGTT. In PCOS, all PCOS patients, you should do OGTT. But in non-PCOS patients also, you may need to do OGTT, right? Yes, OGTT has to be done if there's family history, if BMI is more than 25, if impaired value in past is there. Okay. I am right now teaching you what evaluations are needed before starting the ovulation induction treatment. Know the cause, histories are to be taken properly, weight, height, BMI, semen analysis has to be done. If you are talking about any history of uterine disease, which we'll talk in details, then HSG is very useful test. History of tubal disease, then HSG is important. For uterine disease, transvaginal sonography is important. And if transvaginal sonography or HSG are abnormal, then we think about diagnostic hysterolaparoscopy. It is not the first line investigation. Obviously, hysterolaparoscopy would be too invasive for any patient. First, you have to think about doing HSG, TVS for the disease's history. We in our hospitals, because TB is so common in India, that HSG is done for assessment of uterus. Yeah, In infertile patient, we do HSG. HSG also helps us in assessing whether tubes are patent or not, right? PID is so common in India. So yes, HSG, TVS, if abnormal, then we think about diagnostic hysterolaparoscopy, but take home message that these are basic tests for evaluation of patients who have infertility before starting the ovulation induction agents. Yeah, guys and girls. So yes, these are the basic pre-treatment evaluations. Okay, let us jump on to treatment modality. Treatment modality for ovulatory disorders. Treatment modality. So ovulation induction agents. Can it be used for group 1? Yes, sir. Group 2? Yes, sir. Group 3? Never. Group 4? You know, bromocriptine or cabergoline. Yeah, we will talk about them. Group 1, when are you using, what things are you using for ovulation induction? Group 2 would be normogonadotropic normogonadism. But group 3, ovarian failure, you will not use ovulation induction for ovarian failure. You will have to use something else which we will cover in infertility. Yeah. Right now I am teaching you the topic called ovulation induction. So forget about the treatment of group 3 because that is not by ovulation induction drugs. Let us talk about the group 1 and the group 2s. So the drug which is used commonly is letrozole. Another drug is clomiphene. Yeah, I'll start with clomiphene, but word of caution, in PCOS patient nowadays the drug of choice is letrozole. Let me start with clomiphene, but word of caution. Okay, are you all with me? Clomiphene, very important drug. You might get a short note, you might get a long question about ovulation induction agents, and that list would be incomplete if you don't talk about this drug. Yeah, it is non-steroidal triphenyl ethylene derivative. Non-steroidal triphenyl ethylene derivative. Function wise, it is selective estrogen receptor modulator. Yeah, it's a selective estrogen receptor modulator. So it has anti-estrogenic effect. Yeah, anti-estrogenic effect in most parts of body. Yeah, guys, it is made up of N-clomiphene plus zooclomiphene. So these are isomers. So 60 to 70% would be N-clomiphene, 20 to 30% would be zooclomiphene. Better for ovulation induction is N-clomiphene, by the way. But then there were, you know, if you have seen medical representatives coming with, you know, so many drugs and their brands, they market in such a way that their drug is the best of them all and this drug has no competition at all. Yeah, when N-clomiphene alone, isolation of clomiphene type came in market, then they started marketing N-clomiphene like anything. But then believe me, clomiphene or this combination, clomiphene or specifically N-clomiphene have got equal effect. So nothing great about giving N-clomiphene alone. Yeah, but take home message, the ovulation induction part of clomiphene is done by N-clomiphene. Yeah, we can say it is a cis form and zooclomiphene is a trans form. Isomers, right? In our 12th standard days we talked about isomers, right? Yeah, N-clomiphene is a cis form. It's the most important. Half-life is short. Half-life of zooclomiphene is long. It gets it remains in the body for long time, but remember this thing, the functionality of clomiphene is by N-clomiphene. Action on hypothalamus, the most important. I am talking about clomiphene. The action on hypothalamus is anti-estrogenic. It reduces estrogen's negative feedback. So if you give clomiphene to a girl, it will sit on the hypothalamus and it will tell to the brain, hey brain, there is no estrogen in the body, do something. So brain will think there is no estrogen in the body, brain will increase FSH levels. Yeah, that negative feedback by estrogen is inhibited. Yeah, so because of that, FSH levels would increase, and FSH levels increase, folliculogenesis would occur, follicular growth would occur, and yes, ultimately a dominant follicle will ovulate. Yeah, so yes, this is action on hypothalamus. On pituitary, action on pituitary, it is responsible for increasing gonadotropin action. Increase gonadotropin by GnRH action. Increase gonadotropins by increasing GnRH action. So GnRH will sit on the pituitary and it will do a better job of producing gonadotropins. Yeah, so that's action on pituitary. It is sadly anti-estrogenic on reproductive organs. So let's take a case of cervix. Cervix is responsible for producing mucus. A healthy mucus is always estrogenic mucus. Yeah. Unhealthy mucus would be progesteronic mucus. You know, loss of stretchability is progesteronic. That would not be a good mucus for sperm penetration and entry. Yeah. Clomiphene has anti-estrogenic action, so mucus will become thick, which will not be good. Clomiphene will have anti-estrogenic action on endometrium as well. So what will happen? Endometrial thickness will not be great. Yeah. So the bed of the pregnancy will not be great. But does it have any clinically significant effect so that it will reduce the pregnancy outcome? No. So I'm writing not clinically significant. So they have done studies and they have understood that these effects are not clinically significant. May the mucus become bad or may the endometrial thickness be not so good, but outcome, pregnancy outcome and take home baby rates are same. I mean to say are better than not using clomiphene. Yeah, guys, remember it is second most common drug used in PCOS for ovulation induction nowadays. It is most common drug for non-PCOS patients for ovulation induction. If you want to do ovulation induction, let's say there is unexplained infertility patient. You want to do ovulation induction and IUI. Here letrozole is not the drug. Here clomiphene is again the drug. Yeah. For PCOS patient, clomiphene is rank number 2. Yeah. Letrozole is rank number 1 for PCOS. For non-PCOS patient, it is still the most commonly used drug. Yeah. Guys, so wherever I have written non-PCOS, example would be unexplained infertility. Yeah. Unexplained infertility. Use clomiphene plus IUI. We don't use letrozole plus IUI in these patients. Somebody has asked, Dipanvita has asked, sir, class is up to 9 p.m. Maybe 9:15. But yeah, 9. Okay. Alright. Yeah, I was talking about clomiphene. It is not useful. Mark my words. It is not useful in group 1 WHO patients. Sir, you said group 1 patients can be treated by ovulation induction agents. Those ovulation induction drugs are different. Yeah. Hansween has asked this question. It increases both GnRH secretion as well as action. This is what you have said. This is what you have said. Okay, she's asking. See, understand this thing. that the action on hypothalamus is to increase GnRH. Why? Because it is anti-estrogenic. Estrogen will inhibit the GnRH as well. On pituitary, the action would be, GnRH action would be enhanced. So LH-FSH formation, especially FSH formation, would be increased. Yeah, because FSH is inhibited primarily by estrogen. So anti-estrogenic will increase the FSH. Okay, Ansween? So take home message, yes, GnRH secretions are increased, GnRH action for producing FSH is also increased. Okay, am I clear about this? So yes, two actions over there. I said clomiphene is not useful in group 1 WHO. Why? Because they are hypogonadotropic hypogonadism. Yeah, the fault lies somewhere here. You cannot treat them by clomiphene. Okay. Guys and girls, the regime used is day 2 to day 6 or latest by day 5 to day 9. The starting dose should be on day 2 or day 3 or day 4 or day 5, but you have to give for 5 days. The starting dose is 50 milligram OD for 5 days. Okay. Yep. Those who have tendency to develop ovarian cysts. Yeah. I'm not telling you ovarian cyst patient. I'm telling you patients who have tendency to develop ovarian cyst. Like a patient who developed ovarian cyst on 50 milligram. In those patients, lower dose may be tried. Yeah. If patient developed ovarian cyst on 50, don't give 50 now. You give 25 milligram. So small. In fact, smallest dose is 12.5 milligram also. I have given one 12.5 as well. So 12.5 is the smallest dose. There is one thing called as stair-step protocol. Yeah, Ansween, all good? Stair-step protocol. Now this is interesting. See, generally in your OPD, what you do? I will tell you what you do and what is stair-step protocol. In your OPD, you give 50 milligram, tell her day 2 to day 6 or day 5 to day 9 or in between. For 5 days she has to take, and then folliculometry you might be advising them for assessing the follicular growth. We are not here for diagnosing an ovulation. Here we are for assessing the follicular growth. So ovulation induction and then folliculometry, you advise them. Sometimes they may progress, they may have follicular growth and ovulation. Sometimes they may have no ovulation. So you have missed that treatment in that cycle because ovulation did not happen. Now you will call her up again the next cycle. You might give her 100 milligram. If they do not ovulate on 100, then you will tell them to come up again for 150 milligram. FDA has approved till 150, though 200 milligram doses are also given, but uncharted. Your answer is 150 milligram as the maximum dose. So you have wasted 3 cycles in order to know whether patient is going to ovulate or not with clomiphene. Why don't you use the same cycle to know how much dose is needed? That is stair-step protocol. What is stair-step protocol? Listen carefully. You have to start clomiphene from day 5 to day 9 and the dose is 50 milligram. You have to do ultrasonography, that is transvaginal sonography, from day 11 to day 14. Yeah. Your target is a dominant follicle of 15 millimeter. Yeah, this is what you want, na? Patient should have a dominant follicle so that it ovulates. What if the target is not achieved in this sonography which you have done on day 11, day 12, day 13, day 14? Yeah. Sana, 12.5 milligram is used when patients have formation of large ovarian cysts, even on 25 milligram. So they will have to be given 12.5. We don't want them to have hyperstimulation. No? So remember this thing, 12.5 is the smallest dose, but the starting dose is never 12.5. Starting dose is always 50. See in your hospital, they will always give 50. Your seniors will always give 50. They can reach up to 150. Yeah, I have never given 200. Let me tell you that also. Yeah, 150 is the maximum dose I have given, and yes, that is what is FDA approved. I am right now teaching you stair-step protocol, which will help in knowing the dose required in the patient in the same cycle. So day 5 to day 9 you gave 50. USG was done from day 11 to day 14. You wanted target of dominant follicle 15 millimeter, but you did not get it. Target not achieved. You will not waste this cycle. You will give her clomiphene again, 100 milligram, yeah, for 5 days. So day 10, day 11 to day 14 you are given, and you have not achieved the target. Day 15 to day 15, 16, 17, 18, 19, day 90 you give clomiphene 100 milligram, and then you do USG again, yeah. This time if you have achieved the target, congratulations, her dosage requirement is 100 and she will ovulate with that. Dominant follicle achieved, yeah. Guys, if target is still not achieved, then you have to give clomiphene 150 milligram for 5 days, and then USG after 1 week. Sir, will she not menstruate in this big cycle? Buddy, try to understand this, that she has not ovulated. So luteal phase has not yet happened. Her endometrium will not reach the destination. So menses would not happen in this cycle. Are you getting my point? So in the same cycle, you doing what? Stair-step protocol in order to know the dose of clomiphene. This is very good method of knowing clomiphene without wasting 3 cycles, which you would have done if there was a failure of 50, failure of 100. In the same cycle you would have understood. In the same cycle you would have understood whether 150 is successful or not. Okay, so this is called stair-step protocol. Okay. Not many people know this, that's why not many people use this protocol, but this can be used for sure. What are the results? Believe me, most of the patients ovulate with 50. Most of the patients. If not, then 150 is the maximum dose. 70 to 80% ovulation would happen. Cases would have ovulation. USG is always done 1 week later, Sana. Whenever you stop clomiphene, that day is to be counted, and then 7 days later on you have to do USG for 4 days. That is stair-step protocol. Yeah, result 70 to 80% patients will ovulate. Success, yay, we have achieved ovulation. We are here not to achieve ovulation only. We are here to achieve pregnancy. Yeah, guys and girls, if patient's age is more than 35, BMI is more than 25, or there is hyperandrogenism, these things would decrease the success. Maximum dose, Sana, is 150 milligram FDA approved. Your answer is 150. Yeah, guys, girls, your answer is 150. Sana has written failure of induction. Ovulation induction, I mean to say. Sana, don't confuse this with induction of labor. Okay, failure of induction. Ovulation induction. If 150 doesn't work, then this is clomiphene failure. Okay, failure of induction. Sir, 150 milligram from day 19 to day 22. Try to understand this thing, Radhika, that once you started the treatment of stair-step protocol, first you gave it from day 5 to day 9. Day 11 to day 14 you did sonography. If you have not achieved target, day 15 to day 19 would be the answer for second thing. Day 15 to day 19 would be the second thing. Second what? That means clomiphene 100. Day 19 would be the last dose of 100 clomiphene. 7 days later, that is day 25. You will start doing sonography for 4 days in order to see you achieve target or not. Day 25, 26, 27, 28. You will see whether you achieved the target or not. Target is 15 mm of dominant follicle. Yeah. So 25, 26, 27, 28, you have checked whether you are successful or not. If you are not successful, then day 29, 30, 31, 32 and 33, that means 5 days of clomiphene is to be given. That is 150 milligram. And 7 days later on, you will do sonography to see whether you are successful or not. I know you are talking about the treatment protocol of so many days in the cycle, right? You are probably calling her up so many times that she will be fed up. But this is what is stair-step protocol. Otherwise, you are going to lose 3 cycles. You are going to lose 3 cycles in order to achieve ovulation. This is stair-step protocol. Am I clear about this? Hansveen has asked, so sir, in non-ovulating patients, how does day 2, day 5 happens? Is it after progesterone withdrawal? Hansveen, try to understand this, that clomiphene is going to act on ovarian cycle, not endometrial cycle. Yeah. If patient has had estrogen breakthrough bleeding, yeah, then that will be considered as day 1. Na? You have to give from day 5 to day 9, or you may give from day 2 to day 7, day 2 to day 6. But try to understand, if patient has come to you with amenorrhea, doctor, I have not got my period since last 3 cycles. Can you give them clomiphene cycle? Can you start clomiphene in them? The answer is yes. You don't have to wait for menses to start ovulation cycle. Yeah? You can start clomiphene then and there only. Rule is, you have to rule out pregnancy. She should not be pregnant. Okay, so Ansween, try to understand this. Very good question asked by Ansween. Sir, what if, in fact, I am modifying your question. She has written a question. How does day 2 to day 5? Is it after progesterone withdrawal? Any bleeding would be considered as a day 1. May it be progesterone withdrawal or estrogen breakthrough. That would be considered as a day 1. You have to start from day 2 to day 5. Am I clear about this? As late as day 5 to day 9 would also be fine. Yeah, day 2 to day 6 or day 5 to day 9. But then what if patient is amenorrheic? You can start anytime. Just rule out pregnancy. Am I clear? Hina, your question is what to do when 150 milligram is not working. I'm teaching you, I'm going to teach you what to do when there is a failure of anti-estrogenic agents. I'll talk about it for sure. Sana, yes, in 1 cycle. That stair-step protocol is in 1 cycle only. Am I clear? Sounding very complicated, but try to listen to the session very carefully. These things are done by us in our infertility OPD. Yeah, and these things are to be understood by heart. What is clomiphene? How does it act? Everything is to be understood. What is the maximum dose? What is the minimum dose? What is the starting dose? All these things are to be understood. Got it? Very clear? What if patient comes with amenorrhea and she wants to have a pregnancy? Then you can give ovulation induction after ruling out pregnancy. Don't give clomiphene when she is already pregnant. Don't do that. Yeah. So guys, girls, I said results, 70 to 80% patients will ovulate. Success would be less if age is more than 35, BMI is more than 25, hyperandrogenism. So if they can control the BMI or you can control the hyperandrogenic effects, then the results would be amazing. Pregnancy rate would be 70 to 75 in 6 to 9 cycles, which is very nice. Clomiphene 70 to 75 in 6 to 9 cycles, underline 6. Yeah, guys, why 6? Because remember, continuous maximum cycles which can be given would be 6. Overall maximum cycles which can be given would be 12. Don't give for more time. Unnecessarily resistance would occur and then time would be lost. Yeah. So pregnancy rate 70 to 75. If you are talking about fecundability of clomiphene cycles, 15 to 22%, which is really very nice. Normal fecundability is 7% per cycle in 1 year of intercourse. Yeah, So yes, fecundability is obviously increased with ovulation induction, provided you have correctly diagnosed this as anovulatory disorder of group 2. Don't give it in group 1. It's useless in group 1. Okay. What are the side effects? Any anti-estrogenic drug will have hot flushes. Yeah. Exception is there. I will tell you the exception. That is letrozole. Letrozole has very less hot flushes. But remember, side effect, hot flushes, headache. Yeah. Breast tenderness. Yeah. Pelvic pain. Nausea. Yeah. Very dangerous for the patient, very alarming for the patient is visual disturbances. You know, visual disturbances may be blurring of vision, or they may have photopsia. Yeah. So I'm seeing some image, and if I look somewhere else, I see that image for some seconds continuously. Yeah. So visual disturbances may be there, blurring of vision. If it is there, then the best thing is abandon the treatment. Though it will be reversible, but it's very alarming for the patient. So we have better alternatives. Abandon the treatment. Okay, got it. Other things can be taken care of. So headache, breast tenderness, pelvic pain, NSAIDs can be given. Yeah. Hot flushes will be temporary, they will not be permanent. In fact, 5 days of treatment, she may suffer from mild hot flushes. Those hot flushes will not be long lasting. Okay. Risks. Now, any ovulation induction, risks would be number 1, multifetal pregnancy, which would be seen in 7 to 10% cases. There is no evidence of anomaly in fetus who is exposed to clomiphene or pregnancy derived from clomiphene induction. Yeah. Risk of OHSS, ovarian hyperstimulation syndrome. Thankfully, very rarely it is seen, and most commonly it will be mild OHSS. Ovarian hyperstimulation syndrome would be covered by me in details, but try to understand, in mild ovarian hyperstimulation syndrome, there is abdominal discomfort, nausea, vomiting, diarrhea, abdominal distension, which will require expectant management and nothing else. Yeah. Why headache? Hina, try to understand that this clomiphene is anti-estrogenic, acting on the central nervous system as well. So try to understand, in PMS what happens. In PMS, some patients develop headache. Yeah. Why? Because there is estrogen withdrawal. Yeah, estrogen withdrawal has some effect on central nervous system, and you know that clomiphene acts as anti-estrogenic on the brain. So it will have an effect, and yes, headache may be seen, but it is mild and yes, easily taken care of. Okay, Sana has asked, why burning, why blurring? Again, central nervous system action, anti-estrogenic. Estrogen receptors are there in central nervous system and every part of the body, and yes, the effect on the occipital part would also be there, and that is why blurring. Okay, so yes, there are risks like multifetal gestation. Ovarian hyperstimulation syndrome, even though it is very rare, it is there, and most commonly it will be mild, which will require expectant management. There is no evidence of increase in breast cancer and ovarian cancer. Now, there are many studies which have said that there is mild increase in breast cancer incidence, but then meta-analysis of many studies have clearly mentioned there is no evidence, foolproof evidence that yes, indeed, ovulation induction increases risk. So we would say no evidence of increase in breast cancer or ovarian cancer. Remember this thing. Okay. So yes, This is about clomiphene. Is it used alone or in a combination? So it can be used in combination with adjuvants. Yeah, adjuvants. What are the adjuvants which can be used? A, glucocorticoids. Example, 5 milligram of prednisone or 0.5 to 2 milligram of dexamethasone. Yeah, so glucocorticoids from day 5 to day 14 would be very useful, especially if DHEAS is raised. See, the logic is glucocorticoids will inhibit the ACTH and ultimately there will be inhibition of androgen production, and that would help in the improvement of outcome. Is it like first line? All patients should be given Dexa? No. The first line is always letrozole or clomiphene for ovulation induction. Yeah, glucocorticoids may be given if there is a failure of clomiphene therapy or letrozole therapy, and if you initially only you know that DHEAS is raised. How will you know DHEAS is raised? When there are hyperandrogenic effects and hirsutism, you always do serum testosterone levels, and testosterone levels are high. You always do DHEAS to rule out adrenal cause or adrenal pathology. Yeah, so glucocorticoids are useful as a combination with clomiphene as second line, not as a first line. Yeah, second combination which we commonly use is metformin. Is it used in all patients? No, there has to be indication of metformin present, and you have become champions now in indications of metformin. If there is impaired glucose tolerance, impaired fasting level, diabetes, HbA1c is raised, and she has anovulatory infertility, you better give clomiphene with metformin. Yeah, if there is indication of metformin, you give it. Yeah, guys, girls, metformin in isolation, I would say no, but clomiphene metformin, yes. Okay, got it, guys. Then you know that sometimes this HCG injection is given. 5,000 international unit of HCG or recombinant HCG is there. Then 250 microgram HCG is given if dominant follicle has reached 18 millimeter. Now this is commonly used technique to cause ovulation, but let me tell you the studies. Studies have said that this injection is useful if there is failure of LH surge. So in those cases, where there is failure of LH surge is documented, in those cases this is like compulsory. HCG is brother of LH, and ovulation is done by LH surge. If LH surge doesn't happen, the cyst would be formed. There will be luteinized unruptured follicle. Yeah, so try to understand this thing. The ovulation would not happen. Guys and girls, try to understand that in those patients where there is failure of LH surge, which is documented, then HCG is very useful. In our private practice, we give HCG for all patients when the dominant follicle size reaches 18 millimeter. Theoretically, it is used for patients who have failure of LH surge. Okay. Okay, somebody has asked question. Okay, let me see. Sana has asked, should we do GTT before DEXA? Sana, do we do OGTT for PCOS patients? The answer is yes. Do you? I think Sana, you were not there when I covered the topic called PCOS treatment. All PCOS patients must undergo OGTT, and some non-PCOS patients may also undergo OGTT. If there's family history, if there's BMI more than 25, you should do OGTT in them. Yeah. Sana has asked another question. And should we do DHEAS? when you are suspecting adrenal pathology, then DHEAS values are to be taken. More than 700 would be marker of adrenal tumor. The treatment modality would change drastically. Yeah, if you are suspecting adrenal pathology, then yes. Okay, Sana, I think you were not there in PCOS chapter. When we were discussing PCOS chapter, I told them. Okay, guys, girls. Somebody has asked this question. Ayushi has asked, how will we know there is failure of LH surge? Ayushi, I just now spoke about something called as LH kits available in market. Yeah, LH kits are available. If you are seeing only one line, in all the 5 packets which you are given in I know kit, then you know that LH surge has not happened. Okay, try to understand this week clinically. Do not do I know kit for knowing whether LH surge has happened or not in these patients. But there are LH kits available in market. You can use those kits and you can know. Am I clear about this? Yeah. So yes, we can know ovulation we can know LH surge has happened or not if we do I know kit. I mean to say urinary LH kit assessment. Okay. HCG PG Gynae HCG textbook wise only once. Yeah. When do you do HCG? When dominant follicle is seen as 18 millimeter. This is seen on folliculometry, which we do after ovulation induction. Yeah. Some studies have talked about 2 HCG injections. Some studies have talked about HCG injection for ovulation and then HCG for maintenance of corpus luteum. Yeah. Right now I am teaching you the adjuvant treatments with clomiphene in order to achieve ovulation. So 1 HCG injection only I will teach you. Yes, HCG is called trigger. Yes, ovulation trigger is HCG. Hansween, yes, ovulation trigger is HCG. Okay. Folliculogenesis trigger is FSH. Ovulation trigger is HCG. Okay. Right. After this, guys and girls, one more thing which you need to know, that some patients like PCOS have very high LH levels. Very high LH levels. So there is something called premature luteinization of follicle. Dekho madam, sir, the egg should rupture when it is optimal in size and function. If it is luteinized prematurely, it will not produce a good quality egg or it might not ovulate. In PCOS patient, LH is very high. So in such patients, you can give preliminary suppression. How do you do preliminary suppression? Either you use OC pills in previous cycle or you can use GnRH plus OC pills in previous cycles. What will OC pills do? OC pills will make the ovaries silent by inhibiting LH and FSH, and then you give ovulation induction. This is the treatment protocol for patients with very high LH levels, example PCOS patients. Yeah. Rajni has asked about glucocorticoid combination. Listen Rajni, I have covered something called clomiphene treatment, then I am teaching you adjuvant treatments with clomiphene. A was glucocorticoid like prednisone 5 mg or dexamethasone 0.5 is the starting dose. Dexamethasone 0.5 mg given from day 5 to day 14. What will that do? See, the ultimate aim is that ovaries should ovulate, and for ovary to ovulate the androgenic excess levels should be inhibited. Na? Ovaries do not ovulate well when androgens are in excess. So dexamethasone or prednisone, these are glucocorticoids, they will inhibit ACTH and hence androgen levels would be suppressed. The outcome would be wonderful, especially if DHEAS is highly raised. Yeah. Do we use in all patients of PCOS? No, we don't. We give letrozole or clomiphene, letrozole being the drug of choice. Adjuvants are given only when there is failure of, let me tell you, failure of 3 cycles also you should think about changing the treatment. So if clomiphene is given for 3 cycles and there is no success, you can use adjuvants. Okay, am I clear about this? So glucocorticoid will suppress androgens. Metformin, you know metformin will do what? Metformin is insulin sensitizer. It will reduce the insulin resistance. Insulin like growth factors would be reduced, insulin levels would be reduced, the demand would be reduced, right? And it is said that ovarian action of metformin would be decrease in androgen levels, which would be very nice for ovulation. Yeah, so metformin. HCG is for trigger of ovulation. If there is failure of LH surge if failure of LH surge is documented, then this drug is must. Yeah. And preliminary suppression by OC pills or GnRH is used if there is LH excess, especially PCOS patients. So you have 2 options in PCOS patients. You might use letrozole or clomiphene. 3 cycles you see. If there is no such action, then you have to use combinations. Okay, got it? Alright, guys, girls, so this is about this drug called clomiphene, and you have understood many things about clomiphene. Let us talk about a second type of drug. In fact, the drug of choice nowadays, aromatase inhibitors. Yeah, letrozole. Don't use anastrozole because anastrozole studies failed miserably. Anastrozole is not used, so you will not find anastrozole in the list. Letrozole is a wonderful drug. It's a triazole. Azoles are antifungals, by the way, but they have aromatase inhibition property. Somebody has asked question. Ayushi has asked, sir, HCG will help in rupture of follicle. Of course, yes. HCG will behave like LH. You know, HCG is brother of LH. It acts as luteinizing hormone on ovary, corpus luteum in pregnancy. So, in normal cycle what happens? LH falls and then corpus luteum dies and then menstruation occurs. But in pregnancy, because of HCG, corpus luteum doesn't die. Because of that, progesterone levels do not fall. And that is why patients will remain amenorrheic. Doctor, I missed my period. And you do HCG testing, UPT. Yeah. So yes, HCG is brother of LH. Am I clear about this? Ayushi, okay. Aromatase inhibitor, letrozole, aromatase inhibition. Yeah. When aromatase is inhibitor, you know estradiol levels would reduce. Yes. This reduction would be there in periphery. Okay, guys, girls, so what will be the action on brain? FSH levels would increase. Yeah, estrogen levels would be reduced in periphery. Central action, that means brain action, would be FSH increment. Sana, try to understand that if you are starting clomiphene in any patient, let me tell you, nowadays we don't start clomiphene, we start letrozole. But if you are starting clomiphene, then you give for 3 cycles, and if success is not there, you can use adjuvants. You can add something along with clomiphene as per the indication. Yeah, maximum continuous cycles which you can give would be 6. Yeah. If 6 cycles do not achieve ovulation, then it's failure of clomiphene. Okay, am I clear? Yeah. So these are ovulation, these are clomiphene resistant cases. They are not able to achieve ovulation even on 6 cycles. Okay. So understand, failure of clomiphene would happen. These are resistant cases. Alright, guys, girls. Yeah, if you are talking about, okay. I'll talk about clomiphene failure. I'll talk about clomiphene resistant. Please let me finish this, because nowadays we are not giving clomiphene. That is why those definitions have become outdated, because we are now giving letrozole. Since 2018 this has happened. So letrozole is the drug. We will talk about it. Letrozole, estrogen is formation is reduced because of aromatase action, and FSH would increase in the brain. Yeah. Now this FSH would lead to folliculogenesis. Does it have less estrogenic action on endometrium and cervical mucus? The answer is no. Yeah. So yes, endometrial thickness would be more than in clomiphene, because clomiphene acts on the receptor levels. I mean, estrogen receptors have anti-estrogenic action of clomiphene. That is why endometrial thickness would be reduced. Letrozole doesn't act that way. Letrozole acts by reducing estrogen. Yeah. Thankfully, the reproductive hormone, reproductive organs would not have bad effect of letrozole. That is anti-estrogenic effect of letrozole. Yeah. With maximum dose of 150 milligram. Yes, Sana, 150 milligram is the maximum dose. Yeah, 150 milligram is the maximum dose. First, listen to the letrozole thing. I'll talk about it. Endometrial thickness is more than in clomiphene. Okay. Again, it is ineffective in WHO group 1 cases. See, group 1 patients are hypogonadotropic hypogonadism cases. Yeah, they already have low estrogen in their body. Even with low estrogen, their FSH is also low. So the problem is here. By giving anti-estrogenic like clomiphene or letrozole, you are not going to achieve your target of increasing FSH. The problem is here, not in estrogen. So ineffective in WHO group 1. Okay. Guys, girls, the dosage is 2.5 milligram once a day for 5 days. Again, from day 3 of cycle, for 5 days you will give. Yeah. If there is amenorrhea, don't wait for menses. Then there is nothing called day 3. You start immediately. Amenorrhea, don't wait for menses, just rule out pregnancy. Okay. Success wise, result wise, let me tell you, it is much better. The new studies have said letrozole is more successful than clomiphene. Yeah, 88% ovulation as compared to 75% to 80% ovulation. Nice. Pregnancy rate per cycle 27%, 21%. Live birth rate per cycle, I'm not talking accumulation of 6 months. Yeah, 27% and here 19%. So yes, result wise letrozole is the winner for PCOS. Sir, please explain why ET is more with letrozole once again. Okay. Dr. Thuli, remember this thing that clomiphene is acting on the receptor level. That means anti-estrogenic action is there. It sits on the estrogenic receptors and blocks the receptor completely. And that is why there is anti-estrogenic action. So even in endometrium, it will sit on the receptor and endometrium will not get the boost for endometrial thickness. See, you know, na, I told you proliferation is by estrogen. If estrogenic receptors are occupied by clomiphene, don't expect a very good result on endometrial thickness. Okay, am I clear about this? But regarding the letrozole thing, letrozole is aromatase inhibitor. It acts on the ovary. It reduces estrogen production by aromatase inhibition. That estrogen production is reduced, not completely gone, but that reduction is giving positive signal to brain that estrogen is less, so FSH is increased. Whatever estrogen is produced by ovary will be available for endometrial growth to happen. Yeah, and you're giving it in the early part of the cycle, not in the middle part of cycle. Don't give it in middle part of cycle. You're giving from day 3 of cycle. And once you stop after 5 days, the endometrial thickness would increase. Na? Comparison wise, letrozole endometrial thickness is more than clomiphene endometrial thickness. Yeah. Sana is asking step up protocol. See, 2.5. that protocol which I talked about, clomiphene, is not given for letrozole, by the way, but then you can use the same logic and principle. There it was 50 milligram clomiphene, here it is 2.5 milligram of letrozole. 2.5 can be made 5, 5 can be made 7.5, 7.5 is the maximum dose. Yeah? Am I clear? Yes, Rajni, you are writing that OHSS is less in letrozole than clomiphene citrate. Yes, in fact, let me tell you, OHSS is not documented with letrozole. It is such a wonderful drug. Yeah. Theoretically, it can cause ovulation in OHSS, ovarian hyperstimulation syndrome. But it is not documented that letrozole would do OHSS. Clomiphene is known to cause OHSS, but letrozole OHSS are not documented at all. If you get one, please report it. You might get a good international journal publication. Okay? Letrozole OHSS, not heard of. Okay? So yes, OHSS thing is not heard of with letrozole. Theoretically, it is possible because FSH is increased. What are the side effects? Now, side effect wise, hot flushes are less. Than clomiphene. Headache, cramps, so abdominal cramps. Headache again, see, anti-estrogenic, estrogen level withdrawal will cause headache, just like in PMS patients. Fatigue, dizziness. Yeah. Sana is asking, this is exam question. Acha, Sana, you already given exam, I guess. But letrozole, you have to replace clomiphene 50 with letrozole 2.5. Then if 2.5 doesn't achieve the target, then 5.0 as in clomiphene 100. Then 7.5 as in clomiphene 150. Yeah. Alright. Okay. Alright guys, so side effects you have understood that yes, it will have estrogen withdrawal side effects, but hot flushes are thankfully less. Risks. Theoretically OHS is there, but technically OHS is not documented with letrozole. Multifetal gestation risk is yes, same as clomiphene. Earlier we used to say letrozole means unifollicular ovulation. But then we have seen that according to latest study, clomiphene and letrozole, the risk of multifetal pregnancy is same. Yeah. Congenital anomaly, this was one thing which caused ban of letrozole in 2010. I think Novartis company produced Letroz. I think Letroz was Novartis company. So they won the case, and yes, ICMR did this study that there is no increased risk of congenital anomalies. In fact, world literature also says that letrozole does not increase the risk of congenital anomalies. So letrozole is safe drug in that regard. Okay. Am I clear? Alright guys, so yes, risks are understood by you. This is all about letrozole treatment. After letrozole treatment, let us talk about one treatment which is not the preferred treatment for as a first line ovulation induction. It is always second line. Yeah, it is an option in clomiphene resistant cases. There is option in clomiphene resistant cases. 150 given and they have not ovulated. Clomiphene resistant. 6 cycles over and they have not achieved pregnancy. Clomiphene failure cases. Yeah, so resistant means they have not ovulated. Failure means even after ovulation they have not achieved pregnancy. Yeah. Okay, Rajni has written letrozole more fatigue and dizziness than clomiphene. There is no way of quantification of dizziness and fatigue, but remember both of these drugs have central nervous system effect, and fatigue and dizziness, they come under central nervous system effect of estrogen withdrawal or anti-estrogenics. So no textbook has written which is more and less, but they have clearly written this, that congenital anomaly risk is not high. Second thing they have written, multifetal pregnancy risk is same with clomiphene. Yeah. Hot flushes risk is more with clomiphene, less with letrozole. OHSS risk is only theoretical with letrozole. Clomipene can cause OHSS. Yeah. LOD. What is LOD? Laparoscopic ovarian drilling. Hansween has written, which anomalies were suspected with letrozole? I don't remember exactly, but this is the story of 2010 actually. The anomalies related with central nervous system were there and skeletal, as far as I remember. Hansween, let me be truthful over here. I don't exactly remember why it was banned, but central nervous system and skeletal were the things, if I'm not mistaken. But then latest studies, they say that there's no increased risk. Yeah. So Hansween, please excuse me for that. I really do not know exactly, but as far as I remember, because a thing of like 10 years, 11 years back, it was a CNS and skeletal. Okay. Yeah. So where are we? We are talking on laparoscopic ovarian drilling. We can use electrocautery. So unipolar cautery or by laser vaporization. Yeah, laser vaporization. How many drills are to be done? 3 to 6 per ovary. 3 to 6 sites are selected per ovary. Yeah. Rule is avoid surface near fallopian tube. Why? Because you are iatrogenically damaging the tissue. It may cause adhesions. Adhesion with fallopian tube will hamper the pickup of ovum. Yeah, so adhesion is a well-known effect of laparoscopic ovarian drilling. So you avoid the surface near fallopian tube. Yeah, guys, the effect of ovarian drilling would be that there will be change in the hormonal status in the ovary. Androgen levels would reduce, and this would be very favorable for ovulation. Let me tell you the history behind this laparoscopic ovarian drilling. Steen Bhaiya and Leventhal Bhaiya. You know, this disease Pcos was named after Steen Leventhal. They first saw these ovaries as pearly white and glistening and with very thick outer coating. They thought that the problem of outer coating being thick is causing anovulation. So they tried doing drilling so that ovum can escape out. And ovum escaped out. Ovulation happened. The drilling did not cause escaping of ovum. In fact, drilling caused damage of androgenic theca cells, and the change in the hormonal environment caused effect of ovulation. So this was the history of ovarian drilling. Yeah, pearly white, glistening, thick outer coating, hyperthecosis, theca cell hypertrophy. Laparoscopic ovarian drilling will reduce the androgen levels. And androgens are reduced, the hormonal status would be favorable for ovulation. Yeah, estrogenic environment is necessary for ovulation. Androgen reduction is good. It will help in ovulation. Laparoscopic ovarian drilling as a first line, never. Second line, if patient denies gonadotropin treatment due to any reason, if she is unwilling or if she is unable to do gonadotropin treatment, gonadotropins are costly, yeah, then laparoscopic drilling is the second line. Okay. Which anomalies were suspected? Okay, Kajal has asked a rule of 4. There is something called rule of 4. 4 sites are selected and 4 millimeter depth, and I think watts also 40, something like that, 40 watts of cautery. But then remember, 3 to 6 sites would be optimal. 3 to 6 sites are drilled. Okay. Yeah. So first line is never laparoscopic ovarian drilling. Second line, yes, if patient denies gonadotropin treatment. Sana is asking the difference between unipolar and bipolar cautery. Sana, in your hospital you have seen Unipolar cautery only, I believe, with the coag and cutting element to it. Blue color and yellow color, coag blue and yellow cutting. But bipolars have two probes, and when you touch the bipolar to the tissue, the damage would only be in between the two electrodes of bipolar. So the damage is minimal. Unipolar cautery, you have to apply the plate below the patient, and that cautery damage would happen in a bigger way with unipolar cauterization. We do unipolar cauterization in LOD. Yeah. Yeah. 4 puncture per ovary, 40 words for 40 seconds. Yeah, the third component was 40 seconds. Rule of 4. 4 puncture, 40 words, 40 seconds. Yeah. Good. Yeah, guys, let me tell you that if you are doing diagnostic laparoscopy, hysterolaparoscopy, and you have seen that patient has PCOS, don't directly jump onto LOD because you are not taken the consent. LOD, laparoscopic ovarian drilling, without consent is a crime. Patient should be told, or you take the consent SOS any other procedure to be safe. Because I know certain cases where laparoscopic ovarian drilling has caused adhesions and then infertility, and then patients have had tubal infertility because of LOD. There was a documented case of ovarian failure. The watts were 100 watts used. Yeah, some mistake by the surgeon, and excess current was given, and then there was ovarian failure. So always take a consent. Always explain the risk of adhesions, risk of ovarian damage. So ovarian damage, their AMH levels may be low after ovarian drilling. Yeah, so yes, ovarian damage can occur, AMH levels may fall down, and yes, adhesions are well known risks of laparoscopic ovarian drilling. Okay, am I clear? Success rate or result, 40 to 90% ovulation. See, even with letrozole, the figure was 88%. Here the figures are very variable, 40 to 90%. This is not the first line because we have drugs doing the same job. Yeah, drugs doing the same job. Sana, that 4 millimeter depth, you ignore that. That was my mistake. That is not 4 millimeter depth. I was thinking about something else. Yeah, so not 4 millimeter depth, or 40 seconds. Okay. Depth thing was not there. So result, 40 to 90% ovulation, and yes, after ovulation 50% of them, half of them conceived. But is it first line? No, it is not first line because we have wonderful drugs available. Yeah. Resistant cases, success rate is 50%. And gonadotropin success rate is 65%, 60 to 65%. So obviously gonadotropins are winners, but if patient doesn't have vitamin M, that is money, for IVF cycles or gonadotropin cycles, then you should think about LOD. You may argue surgery may cost more, even more, but in your hospitals, surgery is done by you. In your government setup, drugs are to be purchased by patient. Yeah. So yes, resistant to drugs, LOD would have success rate of 50%, and resistant to drugs, gonadotropin will have success of 60%. Yeah. So remember this thing, we use gonadotropin as the second line. Alright, am I clear about this? Alright, let us talk about the gonadotropin therapy. Yeah, Afrin, 4 seconds. Please excuse me for this. 4 punctures, 40 words, 4 seconds. This is to be written. Yeah, I'm sorry for that. Alright, gonadotropin therapy. Gonadotropin therapy. So these are exogenous gonadotropins. These are highly effective, very costly, very high risk of OHSS, and very high risk of multifetal gestation. Yeah, very high risk of multifetal gestation. All right, my dear friends. So gonadotropin therapy is second line, obviously, when the drugs have failed, like letrozole or clomiphene, or adjuvants along with clomiphene or letrozole. What are the preparations available? What are the preparations? Number one, HMG or menotropins, retrieved from urine of menopausal females. It contains 75 international unit FSH and 75 international unit LH. So both the things are there in 1 ml. Yeah. So ampules are there, HMG ampules, 75 both are there, right, guys? So this injection is given intramuscularly. Yeah, this injection is given intramuscularly. There are purified varieties. So from purified, so highly purified, ultra highly purified, these are purified. There are purified varieties of FSH available in market. LH and proteinary impurities are removed to make it purified. So they will have 75 international unit of FSH with very less LH levels. 1 LH level or 0.1 LH levels or 0.001 LH levels. So many varieties are available. So purified varieties are there, and yes, lesser the LH levels, better would be for the patient of PCOS, because PCOS patients have high LH levels. Yeah, these patients can be given these injections subcutaneously. Yeah, urinary proteins are removed in purification process. Okay, urinary proteins are removed in purification process. All right, guys, girls, you must have heard about this brand name urofolitropin. These are purified varieties of FSH. Okay, guys. Nowadays, we have recombinant FSH varieties available in market. Yeah, called as folitropin alpha, folitropin beta, and the latest folitropin delta. Yeah, these folitropins are recombinants, alpha and beta recombinants from hamster cell line. Delta is from human cell line. Yeah, so recombination will provide only FSH, no LH at all, no impurities at all. Yeah, very costly. But these are better injections for especially PCOS patients. Yeah, guys and girls. So these are the preparations which are available in our hospitals, because our class of patients are coming from middle or lower class. We use HMG therapy because that's a cheaper variety, and yes, we are seeing patients with the group 1 type. Group 1 means hypogonadotropic hypogonadism, and believe me, in those patients LH and FSH both are not there. In those patients HMG would be better than only FSH. Yeah, so try to understand the patients who have no LH, no FSH, you better give HMG instead of recombinant FSH. Okay, by the way, recombinant LH is also available in market. Recombinant HCG is also available in market. Yeah, HCG from urine of pregnant patients, the routine HCG injections are also available in market. These are also gonadotropin preparations. Yeah, recombinant LH, recombinant HCG, HCG injections, the routine HCG injections. Yeah. Now, what are the indications? Indications. Number 1, hypogonadotropic. Hypogonadism. Here we are dealing with group 1 cases. Hypogonadotropic, hypogonadism. You may either use HMG or recombinant FSH followed by recombinant LH. Don't forget LH is important. Yeah, HMG has both. I will better give HMG, it's so cheap. Recombinant FSH followed by recombinant LH. Yeah, that would be, too costly for the patient. But then yes, once you are done ovulation induction, don't forget luteal phase support. Yeah, Rajni, I have written 4 seconds. Luteal phase support is must. So HCG injections, 2000 international unit every 3 to 4 days would be luteal phase support, or you can give progesterone directly. We generally give micronized progesterone 100 milligram for all infertile patients in the later part of their cycle or after IUI. Once you're done IUI, then progesterone support for luteal phase is given by progesterone. HCG can also be used for luteal phase support. Yeah. So yes, number 1 indication of gonadotropin therapy is hypogonadotropic hypogonadism. Number 2 indication would be drug failure. So anti-estrogen resistant cases. So if patient has failed to ovulate, she is resistant. If patient has failed to become pregnant, then failure case. Yeah, anti-estrogen resistant case, that means letrozole failure, clomiphene failure, HMG can be used, recombinant FSH can be used. There is no need of luteal phase support. You are talking about a patient who is group 2 patient, yeah, where you have tried ovulation induction. In those patients already LH is high, yeah, LH is high, so there is no need of luteal phase support. LH is responsible for luteal phase support. So my dear friends, these are the indications. Anti-estrogen resistant cases you should give. Number 3, unexplained infertility. Unexplained, I told you, clomiphene plus IUI for 3 to 6 cycles can be given. If that doesn't work or ovulation doesn't happen, then you can use this therapy. Unexplained infertility, by the way, is that ovulation has happened. Yeah, ovulation has happened, but there is failure of pregnancy. I mean, pregnancy doesn't happen. Then you can give gonadotropin therapy in them. Okay. Am I clear about this, guys and girls? Rajni has asked, can we give luteal phase support in PCOS? See, when I'm talking about luteal phase support, it can be by HCG or by progesterone. Progesterone deficiency is well documented, na? So try to understand that if you want to give luteal phase support in a PCOS patient, you don't give HCG injections. You better give progesterone. Progesterone is a wonderful drug for uterine action as well. HCG will act only on ovary to protect the corpus luteum, but progesterone will have its effect on the uterus as well. It prepares the bed, it makes the bed vascular and healthy for the pregnancy. So if you want to give in PCOS patient, if you want to give luteal phase support in PCOS patient, you can give progesterone, not HCG. Okay, am I clear? Yeah, unexplained infertility is another indication for gonadotropin therapy. Kajal is asking about repetition. Repetition of what? Regarding the need of LH. See, when I told you that gonadotropin therapy is needed in hypogonadotropic hypogonadism, did you understand? In hypo, LH is also low, FSH is also low. The problem is here. There you are giving HMG injection or recombinant FSH injection in initial part of the cycle, followed by LH injections for luteal phase support, HCG injection, yeah, or progesterone support. Better is HCG injection because corpus luteum has to be maintained. Here the preferred luteal phase support would be HCG. Yeah. Why not progesterone? Because corpus luteum produces progesterone along with other hormones as well. So here I want the patient to develop corpus luteum in a healthy way. So I will have to give HCG. HCG is brother of LH. Yeah. In group 2 patients, anti-estrogen resistant cases, that means clomiphene resistant or letrozole resistant, I am giving them gonadotropin therapy like HMG or recombinant FSI. Is there need of recombinant LH? No, sir. Is there need of HCG injection? No, sir. Can we give progesterone support? Why not, sir? Progesterone acts on uterus. Progesterone is a good uterine relaxant and it's very healthy for initial part of cycle. So progesterone support is given. Yeah, but HCG injection? No. Am I clear? Why? Because PCOS patients already have LH excess. Their problem is not LH deficiency like in group 1 cases. Their problem is FSH is less or FSH is low normal. You are giving recombinant FSH. There is no need of luteal phase support by HCG. Okay, am I clear? Alright. Guys, what are the contraindications when you should not give gonadotropin therapy? Contraindications of gonadotropin therapy. I'm seeing the clock for the first time. It's 9:07. I'm sorry guys, but I will take longer time. I will continue the lecture. I hope you people are with me. We started late because of technical issues, so please be with me. Contraindication number 1, obviously pregnancy. You don't give gonadotropin therapy in pregnancy. Number 2, primary ovarian failure. If there is ovarian failure, you don't whip a dead horse. Yeah, gonadotropin therapy would be useless if you are dealing with ovarian failure. If there is uncontrolled thyroid or adrenal dysfunction, if there is uncontrolled thyroid or adrenal dysfunction, first control the disorder. Otherwise, ovaries are not going to respond. Yeah. If there is unexplained abnormal uterine bleeding, don't give it. Unexplained abnormal uterine bleeding, you should not give. Yeah. If there is intracranial lesion, intracranial lesion is again a strict no-no for gonadotropin therapy. Okay. If there is ovarian cyst which is non-PCOS, you never know. Gonadotropins may stimulate ovarian cyst and they may be rupture. Yeah. If there is any sex steroid hormone dependent tumor, sex steroid hormone dependent tumor. Okay, you know, don't give gonadotropin therapy obviously if there is a tumor which is responsive to sex steroid hormones. Okay, so these are the contraindications for gonadotropin therapy. Am I clear, guys, girls? Then let's talk about the regimes, treatment regimes. Here you should remember certain names, treatment regimes. First thing first, there is something called step up regime. These regimes would sound very difficult, but try to understand the meaning, then it will be easy. Step up regime says it all, that you have to step up, you have to increase the dose. So initial dose is 75 international unit. Yeah, initial dose is 75 international unit. This is to be given daily for 4 to 7 days. Alright, you have to check serum estradiol levels, transvaginal sonography, and then titrate. Yeah, guys, girls, you have to step up. If needed, you have to increase the dose, right? Dominant follicle, yeah, when dominant follicle is 16 to 18 millimeter, give HCG injection. Yeah, ovulation will occur in 1.5 to 2 days. Radhika has asked about scrolling up. Okay, I have talked about contraindications to gonadotropin therapy. This is the list containing pregnancy, primary ovarian failure, thyroid adrenal dysfunction, AUB unexplained, intracranial lesion, ovarian cyst which is non-PCOS type, sex steroid hormone dependent tumor. You don't give gonadotropin therapy. Then I talked about treatment regimes. Here there are few names, fancy names. Step up regime says it all. You have to step up. The initial dose is the smallest dose, 75 international unit, 4 to 7 days, and check estrogen levels and TVS. Titrate. Yeah, you are seeing that there is a growing estrogen, growing follicular size, and then estrogen levels are also increasing. Then you can continue, or else you can increase the dose. That is called step up. Yeah, dominant follicle, when it reaches 16 to 18 millimeter, give HCG injection. That would be called a trigger, and that would lead to ovulation in coming 36 to 48 hours. This is step up regime. Now, in PCOS patients, there is a regime called low slow treatment regime. Why? Because I'm afraid of giving FSH in PCOS patients, because even 75 can cause ovarian hyperstimulation. So low and slow. 37.5 is the dose. That is what is low and slow. 37.5 international unit. So small dose. Yeah. Longer stimulation. Small dose, longer stimulation. Yes, PG Gynae, you have to titrate. You have to see the response on dominant follicle levels and estrogen levels. I'll tell you the estrogen levels which are necessary. I'll tell you what is the growth or pattern of dominant follicle. But try to understand that you have to step up. You have to increase the dose if you don't get the response. Yeah, that is called step up protocol. This is low slow treatment protocol which is used in PCOS patients because there is high risk of ovarian hyperstimulation syndrome. Yeah, guys. So yes, 37.5 small dose, longer stimulation. I told you how many days of stimulation was needed in step up? 4 to 7. Here in this case, small dose, longer stimulation of 7 to 12 days, or even more than that in some cases. Yeah, 7 to 12 days. Yeah, so this is used in PCOS patient. Metformin increases success, decreases OHSS. So yes, metformin, whenever there is indication of metformin, don't forget to give metformin. That is in PCOS, low slow treatment regime. Okay, guys, I'll tell you the targets. I'll tell you how to monitor the patients. First, try to understand these terminologies. I have told you step up regime. I have told you low slow regime. There is something called step down regime. Step down regime. Try to think about the normal ovarian cycle. In normal ovarian cycle, don't you think FSH is high in early part of the cycle? Then follicles are recruited, then follicles grow, and then estrogen is formed, which causes inhibition of FSH, and FSH levels will fall down. So initially FSH is high, then FSH falls down to create a dominant follicle. Now that's a normal cycle, and that is what is mimicked in step down regime. It mimics normal cycle. Yeah, it mimics normal cycle, but it is dangerous for PCOS patients because the treatment dose in step down regime is 150 to 225 international unit daily, and then decrease gradually. You don't have to titrate and decrease, you have to decrease. That is called step down regime. So for 4-5 days you are given, 3-4 days you are given, then you have to step down to 75 if you are given 150. If you are on 225, you have to make it 150. If you were on 150, you have to make it 75. You have to step down. Yeah. Yes, it is indeed risky for PCOS patients. Such a high dose, it's obviously risky for PCOS patients, but it has more success. Okay, more success on more risk of ovarian hyperstimulation, obviously. So it is done only after establishing response threshold. What do I mean by this? Step down regime is never done in first cycle. So you are stimulating the cycle, stimulating and making ovarian cycle. Never do step down initially. Yeah, you can do step up, and once you attain optimal dose required for ovulation, that would be her response threshold for ovulation. Let's say you started with 75 and you reached 150 and you saw that she responded to 150. Her response threshold is 150. Then in next cycle, if she doesn't become pregnant, in next cycle you can try step down regime. Yeah, try to understand this thing, that step down regime mimics natural cycle. Yeah, you have to start high and go down, go low. Step up regime, start low and go high. Step down regime can never be first regime. Yeah, guys, girls, see, titration is based on estrogen levels and based on follicular assessment. I'll talk about it, please have patience. Right now try to understand the terminologies. Did you understand step up? You have to increase from 75. You have to see estrogen levels, you have to see TVS, and if response is there on 75, don't increase. Response is not there, you increase to 150. Yeah, see, understand this thing. 75 plus 37.5 can also be done. Yeah, so increment, if you are talking about the incremental dose, it can be 37.5, half the 75, half ml addition. See, 1 ml is 75 international unit, so it can be 1.5 ml, then 2 ml, then 2.5 ml, that way. Am I clear about this, guys and girls? So you have to titrate and see. Step up regime is increasing from 75, step down is decreasing from 225 or 150. It is never the first cycle, it is done after establishing the response threshold. It is risky for PCOS patients. In PCOS, you always go low slow. You may start with 37.5, that is half ml, and you have to give for 7 to 12 days. Slow and slow. Yeah, why do you want to do that? You don't want OHSS to happen. Am I clear about this? There's something called combination regime. You had noodles, you had fried rice, now you want combination rice. So noodles and fried rice combination. What is that? Now, in combination regime, increase the dose for getting response. Yeah, what is response? Dominant follicle. Increase the dose for getting the response, and that response is dominant follicle. Decrease the dose once dominant follicle is formed. So you are increasing as well as decreasing in the same cycle. Okay, you are increasing the dose and then decreasing the dose. This is called combination regime. Apparently this regime has more success than any other regimes. Yeah, time hai thoda, 10 baj jayenge. Okay, so combination regime. Then there is something called coasting. Fancy name. What do you think is coasting? When you are sailing in a boat and then it's a motor boat, yeah, and then you stop the motor, boat will still move in the right direction because there is force behind it, right? Coasting. What do I mean by this? Coasting is withdrawal of FSH support. Withdrawal of FSH stimulation in later stage of development. So once dominant follicle is formed, you withdraw FSH stimulation. Sir, why would we withdraw stimulation? Won't it affect the folliculogenesis? Won't it affect the ovulation? Yeah, guys, this is done to decrease OHSS risk. Yeah, am I clear about this? Now, when you are withdrawing FSH stimulation, that is called coasting. The cycle, once dominant follicle is formed, it goes into the automatic mode. Dominant follicle has the power to produce estrogen. Estrogen will have its effect on LH, positive feedback cycle, you remember? And then understand this thing that positive feedback itself will stimulate LH and then ovulation would happen. Yeah, you don't have to give iatrogenic something. That FSH stimulation is withdrawn. That is called coasting. Okay, guys, girls. So coasting is done in order to reduce OHSS risk. Am I clear about this, guys and girls? Right. So after you understood coasting, let me talk about one more thing. There is something called sequential treatment of clome and gonadotropin. Both the drugs are ovulation induction drugs. Now sequential treatment is same, day 3 to day 7 clome 50, then low dose FSH, that is 75 international unit from day 7. Yeah, from day 7. So technically you are giving a substitute of gonadotropin therapy in the early part. Generally gonadotropin therapy is started from day 2 of cycle. Yeah, day 2 of cycle. Here what I am doing, I am giving clomiphene for initial few days and then FSH. That would reduce the requirement of FSH and hence the cost. So cost reduction would happen. And obviously this would be useless treatment in group 1 cases. Yeah, it will be useless treatment in group 1 cases. Coasting simply means stopping the FSH support. You don't give iatrogenic FSH. That means gonadotropin therapy is stopped. FSH therapy is stopped. What is coasting? Aapne machine chalu ki, you have started a motor. And that motor has propelled the boat in front, I mean forward. And then you stop the motor, the boat will not stop at the same place. It will coast. It will continue its forward journey. That is what happens in a case of dominant follicle. Let's say dominant follicle is formed. You may do coasting. Coasting regime is stopping the support. Yeah. When you stop the support, it automatically reaches its destination. That is called coasting. It is done in patients who have high risk of OHSS. Am I clear? See, combination regime is stepping up. Combination regime, what did I teach you in combination regime? Step up and step down, both are used. Yeah? Combination regime, step up and step down, both are used. Initially, you use high dose for getting the response, that is formation of dominant follicle, and then decrease the dose. You have to reduce the dose so that only one dominant follicle is formed. What is the advantage? What will be the feature of this combination regime? That less number of ovulations would occur. So multifetal gestation, chance of multifetal gestation with combination regime would be less than in any other regime. Yeah, you want one dominant follicle to ovulate. Yeah, am I clear? So less number of ovulations in same cycle. See, you know, gonadotropin therapy may cause multifetal gestation, triplets, quadruplets. Imagine 4 follicles are formed. Yeah, 4 follicles are formed. Combination regime would reduce the risk of that thing. You want only one dominant follicle to happen. Am I clear about this? Guys, combination is giving high dose to achieve the target of dominant follicle and reducing the dose once dominant follicle is formed. Okay, am I clear about this? Increasing the dose to get the response. So you start with 75, then you make it 150, and if you achieve target at 150 dominant follicle, then you again make it 75 in order to achieve one ovulation. Am I clear about this? Okay, guys. So yes, sequential treatment is responsible for cost reduction. Yeah, there's something called adjuvant treatment with long acting GnRH agonist. Adjuvant treatment with long acting GnRH agonist. What will GnRH agonist do? I told you, suppression. Suppression of previous cycle will give a better response in this ovulation induction. So suppression of ovarian cycle by GnRH agonist, which is long acting, is of two types. Long protocol for luteal down regulation, yeah, long protocol for luteal down regulation, and then there is long protocol for follicular down regulation. I know you are hungry and tired, but give me 15 minutes, guys. I know I am taking lots and lots of your time, but give me 15 minutes. I need to finish off this topic and I was already late. I started at 5:30 because of technical issue. So guys, have patience, have patience. Rule number 1. Whenever you want to start gonadotropin, it is from day 2 of cycle. Now you want to do something called as adjuvant treatment with long acting GnRH agonist. What is the advantage? Previous cycles would be suppressed by GnRH agonist, and then you are giving gonadotropin for a better result. Yeah, guys, that suppression can be started in luteal phase of previous cycle or in follicular phase of previous cycle. That is long protocol for follicular down regulation or luteal down regulation. Let me make a timeline. Yeah. What am I drawing over here? Listen carefully. Day 2 onwards, you are supposed to give the gonadotropin therapy. Mid cycle, when you achieve dominant follicle size of 16 to 18 millimeter, I will underline 18 millimeter injection HCG. I'll give HCG. I'm writing day 14. It could be any day where follicle is achieved. Dominant follicle of 18 millimeter is achieved. Yeah. Now listen carefully. If I give GnRH, if I give GnRH for suppression, if I give GnRH for suppression of previous cycle, it is called long protocol. This is what? This is long protocol for luteal phase down regulation. That is why it is given from day 22 of previous cycle. Yeah, that would inhibit the gonadotropins from the pituitary due to GnRH agonist from day 22. That is what is luteal phase of previous cycle. Yeah, if you are giving, let me use another color. If you are giving GnRH from day 1 of previous cycle, continue till HCG injection of this cycle. This is called long protocol for follicular phase down regulation. Yeah, long protocol for follicular phase down regulation. Guys, push, push and push. My dear friends, I know you people are hungry and tired, but please push. Yeah, you will deliver the baby today itself. Okay, I am teaching you long protocol. These drugs are GnRH for down regulation. Yeah, if you want to suppress right from follicular phase of previous cycle, you have to give from day 1 of previous cycle. If you are giving from day 22, you are doing a luteal phase down regulation. See, these are all the things which are done. In fact, there is something called short protocol as well. Be ready. Short protocol coming up your way. Short protocol. In short protocol, the GnRH is started from day 1 of the same cycle. Day 2 onwards, you are giving gonadotropins. These are gonadotropins. But day 1 onwards in the same cycle, this is called short protocol for GnRH. Please draw this timeline diagram in order to understand what is short protocol. Long protocol of 2 types. Yeah. All in all, the plan of action, I will tell you the crux of the situation. I do not want impurities. I do not want impurities, which would mean LH would be an impurity of PCOS patients, which would affect the ovulation of this cycle called gonadotropin cycle. I want to suppress that. If I am suppressing from luteal phase of previous cycle, that's long protocol for luteal phase down regulation. Yeah. If you are suppressing from day 1 of previous cycle, that's long protocol for follicular phase down regulation. The target is the GnRH is to be given till the time you are giving HCG injection for trigger of ovulation. Okay, guys. Now, $1 million question which you are asking again and again: how to monitor? Monitoring. See, you have understood many names: step up, step down, combination, low and slow, long protocol, short protocol, sequential treatment, adjuvant treatments. Many studies are there. They are telling the superiority of one over other, but then try to understand these are the protocols. Why down regulation is done? Ayushi, what is the plan? Why I want the patient to stop producing her pituitary LH you are giving gonadotropin therapy iatrogenically so that ovaries behave properly. By behaving properly, I mean to say they ovulate properly. I don't want them to have premature luteinization, which would be bad. I don't want this patient to have failure of ovulation, which would also be bad. So timing the hormonal status is very important. Especially in PCOS patients, GnRH agonist therapies or even ocipal therapies are used to down regulate their own LH levels. Yeah, guys, girls, if you are down regulating from luteal phase or from follicular phase, these are called long protocols for GnRH. If you are down regulating from day one of the same cycle, that's called short protocol. Am I clear? What is the plan of action? I want a good healthy egg which is to be released. Yeah. In fact, before releasing, you can do ovum pickup if you are planning IVF cycle. Yeah. I want a healthy egg, not prematurely luteinized egg. And for premature luteinization for avoiding premature luteinization, you have to down regulate her own hormones called LH. And obviously FSH, because you are giving GnRH, both will be inhibited. You are iatrogenically controlling the ovary. I have tried to make this simple. I know it's a difficult concept, but try to understand that ovaries have to do their job, and abnormal hormonal status in the patient's body is not allowing our treatment to work. So by down regulation, you are helping the ovaries to work under your control, and your control is gonadotropin treatment. Okay. Am I clear about this? Alright, monitoring. What do you want? The plan is ovulation is needed. OHSS is to be avoided. Minimize multifetal pregnancy. Yeah. Serum estradiol will help you out, and transvaginal sonography. So these are the things which are used in order to monitor. Yeah. Now let's hear about estradiol levels. To be done early morning. Yeah. Because gonadotropins are given in evening. 5 p.m. to 8 p.m. is the time of giving gonadotropin. Yeah, gonadotropins are always given in evening, and yes, estrogen levels are to be checked in early morning. Ayushi has asked, if follicular phase down regulation is done, will follicle mature? Try to understand. Follicular phase down regulation means previous cycles follicular phase is down regulated. From that time you are down regulating the pituitary of the patient. Pituitary will not produce its hormones, especially LH. And you are iatrogenically giving. See, follicles will mature because you are iatrogenically controlling the follicles by gonadotropin therapy. For long protocol and short protocol, GnRH, and for ovulation induction, gonadotropin. Correct, Nigunj. Yes, you are right. Absolutely. You have heard these terminologies many times in your textbooks, and your seniors might be discussing, but you always found it difficult to understand. I want to iatrogenically control ovary. How is ovary controlled? Gonadotropins. How is uterus controlled? If you want to regularize the cycles, I want ovaries to remain silent. Hey ovary, remain silent. I will give estrogen and progesterone. That's why endometrial cycle is well controlled by occipals. Uterus will behave normally with occipals. Estrogen, proliferation; progesterone, secretion; withdrawal, menstruation. Regularization of cycles would happen. If I want ovaries to work well, hey ovary, work well, I want pituitary to remain silent. Hey pituitary, you shut up. I want to control ovary. How do I want to control ovary? Gonadotropin therapy. Hey pituitary, you shut up. How will pituitary shut up? By gonadotropin releasing hormone agonists, which are continuously given, and pituitary will stop forming LH and FSH. Now you are the only one who is controlling ovary. That is what is the meaning of down regulation. Yeah, am I clear about this, guys? I know it's a very heavy thing, Okay, but yes, that's the thing. So when is estrogen level done? It is to be done early morning. Gonadotropins are given in the evening. Estrogen should ideally double in 2-3 days. That's our target. Estrogen should double every 2-3 days. In normal cycle, you will find doubling up and then the maximum levels of 200. I'm writing normal cycle. Peak is 200 to 400 picogram per ml. In gonadotropin cycle, peak is 100 to 1500 picogram per ml. Remember these figures. Remember these figures. Yeah, that's a peak. That's what we want. Imagine patient having estrogen levels of 2500 or 3500. She might be a case of ovarian hyperstimulation syndrome. You might have to do coasting. You might have to avoid HCG injection. Yeah. Try to understand the things based on hormonal status. Yeah. Alright guys, so yes, in gonadotropin cycle, peak is 500 to 1500. What's your target? Estrogen should double in 2-3 days. What about USG? Now, listen to the transvaginal sonography targets. The cohort, that means multiple small follicles, should be seen at day 5 to day 7. Yeah. Dominant follicle. What is dominant follicle? A follicle whose size is 10 millimeter or more. Dominant follicle should be seen by day 8 to day 12. Growth of the follicle 1 to 3 millimeter per day. That's the target. This is what I was teaching you, that this target is to be titrated. If you are achieving that target with 75, don't step up. 75 would be constantly given. If you are achieving the target, growth is 0.5 millimeter per day, that 75 is inadequate. You have to make it 1.5 ml. 75 plus 37.5, 112.5 would be the answer. If that is also not achieving the growth rate of 1 to 3 millimeter per day, then make it 150. Try to understand, that's called titration. Dominant follicle should be seen by day 8 to day 12. Yeah. The 20 to 24 millimeter is the size of dominant follicle at LH surge. अंडा फूटता कब है? जब वो राइप होता है. Premature luteinization is bad. 20 to 24 millimeter at LH surge, this is optimal. Let me tell you that if follicle is of 15 to 16 millimeter, 40% would ovulate. Yeah. Only 40. This is the maximum size, 40% would ovulate. 17 to 18 millimeter size, 70% would ovulate. 19 to 20 millimeter size, 80% would ovulate. And anything more than 20 millimeter size, virtually all will ovulate. Yeah. So you know that the follicles are growing. 10 has become 11, 11 has become 12, that's nice. But 10 has become 10.5, 10.5 has become 11, you have to increase the dose in step-up protocol. Am I clear about this, guys and girls? Yeah. So guys, this is about USG targets. 1 to 3 millimeter per day, and yes, estrogen targets doubling in 2 to 3 days. 2 to 3 days. Yeah. Gonadotropin peak, estrogen peak in gonadotropin cycle 500 to 1500 picogram per ml. Radhika, I am so proud of you. Radhika has given one protocol called antagonist protocol. Radhika, you know the drug called cetrorelix and ganirelix. In fact, I should have told you antagonist protocol. But in this diagram, since you were so tired and giving me weird statements, even I missed out that. Antagonist protocol. There is one protocol called antagonist protocol. Things are same. You have to give gonadotropin from day 2. But here, day 10 to day 14, I mean to say day 9 onwards, after day 9, GnRH antagonist. are given in antagonist protocol. Yeah, that is antagonist protocol. Antagonist will do the same job of preventing premature luteinization, especially seen in PCOS patients. So there is something called antagonist protocol, as correctly told by Radhika. Radhika, yes, good point. GnRH antagonists are given after day 9 till the time you give HCG, and antagonists would prevent premature luteinization. Okay, guys, girls. Nikunj is asking day 8 to day 12 daily TVS. No, it is not clomiphene cycle, my dear friend. Nikunj, when I am talking about transvaginal sonography, this is never day 9 to day 11 to day 14 as in clomiphene cycle. This is gonadotropin cycle. You have to titrate the dose according to the response. So folliculometry in gonadotropin cycle is done from day 5 onwards. Yeah, you see the response, and titrate accordingly. So folliculometry is done in gonadotropin cycle in day 5 onwards. Patient might have to undergo folliculometry for many days, but that is what is needed. Yeah, who said बच्चा पैदा करना बच्चों का खेल है? Never. बच्चा पैदा करना बच्चों का खेल नहीं है. Yeah, and yes, infertility is one clear-cut condition where so much of patience is needed by the patient and the doctors. Yeah, I'm teaching you the gonadotropin therapy and yes, monitoring therapy in gonadotropin therapy. Yeah, monitoring protocol in gonadotropin therapy. Let's talk about results. Results. 90% success in group 1 cases. Yeah, 90% success in group 1 cases. Fecundity 25%, which is really very nice. Pregnancy rate after 6 cycles 90%. Abortion rates are slightly higher than general population. 25% pregnancies as compared to 15% normal cases get aborted. Yeah, guys, regarding group 2 cases, success is 30 to 60% after 6 cycles. So group 2, that means normo, these patients have less success. Androgens would decrease the success even more. That is why the long protocol, by suppression of by GnRH agonist therapy, you are suppressing the ovarian function and androgens will also reduce. So that is why these new things have come, so that the success is increased. Ultimate aim is to achieve success. Group 1, these patients, I can give it to you in writing that their problem is solved. But group 2, the success is not that much. Okay. Now let's talk about risks. What are the risks? Number 1, multi-fetal pregnancy. Mubarak ho, judwa hua hai. More the merrier is the wrong statement. Multi-fetal is a high-risk pregnancy. Yeah, guys, multi-fetal pregnancy is a high-risk pregnancy. It has high chance of abortion, high chance of preterm, high chance of complications, high chance of so many bad things to the babies and the mother. So multi-fetal pregnancy is to be avoided. ऐसा नहीं कि 2 हुआ तो अच्छा है ना डॉक्टर. No, not at all. So guys and girls, multi-fetal pregnancy is to be avoided. The things which can be done to avoid multi-fetal pregnancy: cycle cancellation, which is very difficult to explain to the patient that we are cancelling because there are 7 dominant follicles and we don't want septuplets, whatever. Try to understand, cycle cancellation is one modality available to avoid multi-fetal pregnancy, but it's very difficult to tell to the patient. She has done all the hard work, but you're cancelling the cycle. Other modality is aspiration of follicles. If they are more than or equal to 3 follicles of 14 to 16 mm or more than 3 follicles of 15 mm. Sorry, more than or equal to 3 follicles of 10 to 14 mm. Yeah? क्या कर रहा हूं मैं? Wait a second. First is cycle cancellation, then more than or equal to 3 of, yeah, aspiration of cycle. Give me one second, let me remember. Aspiration of follicles if they are more than or equal to 3 of 14 to 16 mm. You may do aspiration of follicles if they are more than or equal to 3 of 14 to 16 mm. Yeah, guys. Third is withhold HCG injection if estrogen levels are more than or equal to 1400 picogram per ml. Yeah. What if there are more follicles? Is there any other option available? There's something called rescue IVF. Rescue IVF. Rajni, we will be talking about OHSS after multifetal gestation. What is rescue IVF? You are given gonadotropin and suppose there are 7 or 8 follicles. You don't want 7 follicles to ovulate at the same time. What you will do is, you will do the ovum pickup. You will pick up all these 7 follicles, eggs, and then you will do in vitro fertilization, which was not in the plan. But because the patient underwent the gonadotropin therapy and then the response was more than expected, then you can do rescue IVF. Okay, where you will do ovum pickup. You don't allow ovulation to happen, and then use these follicles, use these ovum, eggs, ova for rescue in vitro fertilization. So these are the protocols: cycle cancellation, aspiration of follicles if they are more than 3 of 14 to 16 millimeter, more than or equal to 3. Withhold HCG if E2 is more than or equal to 1400 picogram per ml, or you can do rescue IVF. Yeah. Let us now talk about the famous risk which is there with gonadotropin therapy called as OHSS. Ovarian hyperstimulation syndrome. OHSS. What is wrong with patient of OHSS? There is increased capillary permeability. Yeah. Why? Because of increased VEGF and other cytokines. Because of increased capillary permeability, there is fluid shift to extravascular compartment. Fluid shift to extravascular compartment. Because of that, there will be hypovolemia and there will be hypercoagulation, thrombosis. Yeah. So OHSS is basically ovaries have become hyperstimulated. Because of that, VEGF is increased. Because of that, capillary permeability is increased. Because of that, there is hypovolemia due to fluid shift and leading to thrombosis. Guys, girls, what are the risk factors? Risk factors of OHSS: young age. So patient who is young, patient who is thin, patient with PCOS, patient with increased ovarian reserve. So AMH is high, or count is high. Yeah. If you are given high dose of gonadotropin, yeah. And last but not least, HCG, the most important hormone to cause ovarian hyperstimulation syndrome. Highest risk I can say is HCG injection. Be attentive, guys. These are the risk factors for developing ovarian hyperstimulation syndrome. Yeah, guys. So ovarian hyperstimulation syndrome can be mild to moderate or severe to critical. So let me give two arrows: mild to moderate, first I'll talk about mild to moderate, where there be ovarian enlargement, what is wrong? Yeah, all right. So mild to moderate, there is ovarian enlargement, lower abdominal discomfort, nausea, vomiting, diarrhea, abdominal distension. These patients are treated by expectant management. These patients are treated by expectant management. You can give analgesics, teach them about the severe factors. I mean to say, if they have any evidence of severe, they should report. So OPD management, but counseling about being vigilant about severe symptoms, which I will teach you. Avoiding intercourse. It is said that these large cysts may rupture due to intercourse, and they have pain with intercourse, so avoiding intercourse is advised. Antiemetics plus higher analgesics for moderate symptoms. Yeah, again, moderate patients are also managed by OPD basis. Yeah, but they have to be told to maintain weight chart, urinary frequency. I said weight chart, frequency chart. We have to do hematocrit, electrolytes, creatinine levels. She has to take fluids more than 1 liter per day. Yeah, hypovolemia is dangerous. Electrolyte rich drinks are available in market. She can use those drinks. She has to avoid pre-exercise. But mild activity is encouraged because there will be less risk of thrombosis with mild activity. Heavy exercise is to be avoided. Yeah. If patient has pregnancy plus OHSS, is a definition for hospitalization. Yeah. Pregnancy plus OHSS, you have to admit these patients. Can pregnancy cause OHSS? Yeah, of course. Those are called late onset OHSS. This is because of HCG which is produced in pregnancy. Yeah, pregnancy plus OHSS, you admit them. Yeah, guys, if patients have severe or critical OHSS, you have to hospitalize them. Yeah, severe or critical OHSS, hospitalize. How do you know they have severe? They will be severe, not getting controlled by painkillers. Severe pain is there. Rapid weight gain, which is defined as more than 2 pounds. They are accumulating fluid in extravascular compartment. So rapid weight gain. Tense ascites. You have to admit the patient has tense ascites, because ascites, they have breathing difficulties. So respiratory. decrease BP. So hypotension, you should obviously admit them. Lab abnormalities like LFT abnormalities or RFT abnormalities, so liver or renal damage is there. Yeah, lab abnormalities, sodium less than 135 milliequivalent per liter, potassium more than 5 milliequivalent per liter, E capital, okay, I have not written E capital, milliequivalent per liter. Hematocrit 35%. Creatinine more than 1.2 milligram per deciliter. Yeah, guys, girls. Yeah, early OHSS is due to exogenous HCG. Late onset OHSS is due to pregnancy HCG. Is it still hanging in between? Because I think there was a problem with the power cord. That's why I removed the power cord. I hope it is not hanging. Let me see. Can you people go back and come back so that it is smooth and normal now? I hope it is okay now. Guys, can you see me? Can you hear me? 2 milligram per deciliter. Yeah, it is. I think it is normal, guys, girls. So severe pain, rapid weight gain, tense ascites, abnormal lab investigation, respiratory distress, hypotension. If there is ovarian rupture which leads to hemorrhage, that is also possible, huh? That is also possible. If there is a DVT, you have to admit these patients. Yeah, you have to admit these patients, guys and girls. So this is about how to define severe or critical patients. Yeah, treatment wise, IV fluids. NS is preferred to RL because they have hyponatremia. Okay, guys. So IV fluids, NS is preferred. Don't give ringer lactate, give normal saline. Slow albumin infusion, 25%, 50 to 100 gram of albumin is to be given in 4-hour interval. In every 4-hour interval. Yeah. Avoid diuretics. You may be tempted to give diuretics in order to achieve urine output, but then avoid diuretics because she already has hypotension, hypovolemia. Okay. If potassium is high, give insulin glucose combination. Yeah. Potassium is high, insulin glucose combination, or even soda bicarb is given. Okay. You have to tap the fluid if there is tense ascites or tense pleural effusion. Yeah. So thoracosynthesis, paracentesis may be used. There are venous thromboembolism stockings. Venous thromboembolism stockings available in market, or pneumatic compression stockings. Pneumatic compression beds are available. Yeah. Then don't forget heparin therapy. Yeah. This is to be continued till the end of first trimester if she has pregnancy OHSS. Yeah. ICU management. So all in all, you are doing therapy which is based on hypovolemia, hypercoagulation, and yes, if there is electrolyte imbalance, you are giving NS normal saline, and potassium is dealt by insulin glucose combination. Okay, guys, how to prevent? You are supposed to identify the patients who are at high risk and you have already written risk factors. How do you prevent? Now you understand the importance of monitoring. Estrogen levels more than 250 picogram per ml or large number of intermediate follicles, yeah, you may attempt coasting. You have to stop giving stimulation. You may attempt coasting. You may delay HCG. By doing coasting, estrogen levels will come down, and by stopping FSH injection, additional FSH injection, number of follicles will also be less. They will undergo atresia. Some follicles will die. Less number of follicles would be there. Yeah, coasting is essential, and delaying HCG is essential. Yeah, if you want to give HCG, you have to continue that cycle, then low dose HCG may be preferred. So delay it and give low dose. Low dose is 5,000. Some people give 10,000, some people give 15,000. 5,000 is low dose. Yeah. Then GnRH agonists. GnRH agonists. Cabergoline. Yeah, cabergoline. This is for treatment as well as prevention. Treatment as well as prevention. Cabergoline is known to have anti-VEGF property, and VEGF is a basic cytokine disturbance which is causing increased permeability of capillaries. Sana has asked ICU management for which patient? If patient is having any major organ failure like renal failure or liver failure, or if there is a persistent hypotension not getting cured by your IV fluid, then you give ICU management. Yeah, kabhi give up kar dena that it is not my job. Seniors or medicine people should see hypotension is correct. Yeah, you have done your treatment called gonadotropin therapy, but unfortunately she developed OHSS. And if you are not able to treat OHSS, send her to ICU. They will manage it. They are better in managing the hypotension and shock. Cabergoline, because it is anti-VEGF, it is used for treatment and prevention. Progesterone instead of HCG. So for those high risk patients, especially PCOS patients, you give progesterone support instead of HCG support. Yeah, 100 milligram vaginal suppository will do the job of luteal phase support. Yeah, so progesterone instead of HCG therapy is to be given in order to prevent HCG induced OHSS. So this is one way of preventing. Yeah, guys, girls, now last thing of the day is one treatment modality which is never heard till now. Which drugs did you hear in this session today? You heard clomiphene, you heard letrozole. So SERMs would be clomiphene. Yeah, SERM would be clomiphene. Some people have used tamoxifen also, but tamoxifen studies are very less, so I can't comment. You heard letrozole. You heard that anastrozole is not used. Then you heard about gonadotropin therapy. Different kinds of gonadotropin therapy. Then you heard about suppression by ocipils or GnRH agonists. Those GnRH agonists were continuous long-acting GnRH agonists, right? Now this is totally different. This is treatment of ovulation induction by pulsatile GnRH. Let me tell you, it is not commonly used. Not commonly used because patient would need continuous indwelling IV catheter. Imagine patient is living with IV catheter even at home. Yeah. Patient would need continuous dwelling IV catheter for how many weeks? For 2 to 3 weeks. Yeah. And pulsations are given as 5 microgram per pulse. Yeah. 5 microgram per pulse. And each pulse is given every 60 to 90 minutes. Now this is very different, na? This is not that continuous GnRH suppression. This is pulsatile GnRH activation. Right? What are the indications? Who all will benefit from this treatment? Number 1, group 1 W. So basically those patients who have hypothalamic anovulation. So hypothalamus is not doing the job properly. You will do the hypothalamic job of giving pulsatile GnRH. Yeah, guys. So you know 5 microgram per pulse is given 60 to 90 minutes, every 60 to 90 minutes. Yeah, that pulse is given. And once she achieves ovulation, then make it 120 to 240 microgram, 120 to 240 minute pulsations of same dose. Sir, what are you teaching, sir? I am mimicking something called as hypothalamic function by giving pulsatile GnRH, 5 microgram per pulse every 1.5 hour. Once ovulation is achieved, then pulsation has to be reduced. Make it 120 to 240 per every 120 to 240 minutes. That means 2 to 4 hours. Yeah. Monitoring is not necessary. Wow. Because ultimately pituitary will produce its own hormones and there will be nothing called ovarian hyperstimulation. Yeah. Monitoring is not necessary. It's optional. Yeah. Results. Obviously, I am telling you that it is because of hypothalamic anovulation. I mean, the infertility because of hypothalamic anovulation can be best treated, can be treated by this. Yeah. 80% pregnancy rate in 6 to 12 cycles. Yeah. It is worst result in PCOS patient. Worst in PCOS because the PCOS patients would have problem of LH excess and FSH deficiency. Pulsatile GnRH will not solve the problem properly in these patients. Am I clear, guys and girls? And yes, guys and girls, we have covered group 1, group 2. Madam had covered group 3. In fact, Madam had talked about ovarian failure, premature ovarian failure. And yes, our infertility chapter would have something called as ovum donation IVF. Group 4 is hyperprolactinemia, anovulatory disorders, which will again be covered in infertility chapter. So today we have covered a lot basically. Oh my god, it is 10:15. Guys, how many of you are still awake? How many of you are still listening to the lecture? Because I have completed the lecture. I just wanted to see. I would be happy even if there are 5 students listening. Give me high five if you have attended the whole lecture. Guys, attended the whole lecture. Give me high five. Say yes sir, or give me thumbs up if you attended the whole lecture. Pulsatile GnRH. Afreen, time is over and we have completed the last thing called pulsatile GnRH. Ayushi, antagonist is different. This is pulsatile GnRH, which is hypothalamic anovulatory disorder. Ayushi, I hope you are trying to differentiate between long protocol of GnRH suppression, which was continuous GnRH, and this is pulsatile GnRH, which is given by IV catheter continuously for 2 to 3 weeks. Nothing else has to be done. Only thing is that you have to give 5 microgram per pulse and no monitoring. Yeah, there is another way of ovulation induction. Okay. How many students are still alive and awake? Give me thumbs up. Okay, PG Gynae is there. Nikunj is there, Anu is there, Afreen is there, Kajal, Dipanjali, yes, give me thumbs up. Give me thumbs up if you are still alive and awake. Radhika is there. Guys, I have tried to cover the very difficult topic in gynecology, and that is ovulation induction. Understanding the basic mechanism and mimicking what is normal is what is needed in this what was needed in this lecture. I would recommend you to listen to the lecture again. It is not a job of one lecture, one hearing and one note preparation. You have to listen to this lecture again and again. I have made these things very simple for you people. Though you will disagree at this point, but once you will revise and once you will write your notes and once you will write all these things which I have written, believe me, you will not need anything else. Okay? So yes, Ayushi has written in treatment of OHSS, GnRH antagonist. See, antagonist basically would prevent OHSS. That's what Dr. Bhargava also said, na? Antagonist protocol is basically meant for reducing the premature luteinization as well as reducing the risk of OHSS. Yeah, we want optimal treatment. Yeah, somebody is writing question. Yes, in OHSS treatment, yes, GnRH antagonist would be for prevention purpose. Okay. Sir, in such ovulation induction cycle, usually there is thin endometrium which prevents implantation. Can we prevent that? Radhika, let me tell you that clomiphene induced thin endometrial thickness and letrozole having good endometrial thickness, studies have said that endometrial thickness per se would not determine your management protocol. So yes, outcome of pregnancy would be same. Okay, am I clear, Radhika? Alright. Advantage of a pulsatile GnRH, no need of monitoring at all. Advantage of pulsatile GnRH, no need of monitoring at all. But then, do you want your patient to live with IV catheter? In fact, in our hospitals, we don't give pulsatile GnRH, which is costly, of course, and IV catheter for 2 to 3 weeks continuously, not good idea. How to give cabergoline in OHSS? 0.25 mg twice a week. Yeah. The cabergoline drug has long T-half, it remains in the body, 0.25 mg and if required 0.5 mg, not more than that. Pulsatile GnRH, how important in clinical practice? Not important in clinical practice, but you should know that there is this way also. Antagonist protocol, I will show you, somebody has asked antagonist protocol, I will show you that diagram where Radhika actually pointed me out that I have missed out antagonist protocol. Before understanding this diagram, see this upper part of the diagram, this is gonadotropin. This from day 2 onwards is gonadotropin. Yeah. If I am giving GnRH agonist, this is continuous, okay? This is long acting. From day 1 onwards, till the time HCG injection is given, this is called short protocol. If I am giving from day 22 of previous cycle, it is for long protocol for luteal phase suppression. If I am giving from day 1 of previous cycle, you are suppressing the follicular phase. So it is down regulation of follicular phase, long protocol. And regarding GnRH antagonist, it is given after day 9 till the injection HCG, that is GnRH antagonist. Shortest is GnRH antagonist protocol. Yeah. Am I clear about this, guys? Pulsatile GnRH, how important in clinical practice? This question is over. Antagonist protocol, this question is over. From after day 9, that is day 10 to HCG injection. Rajni is asking again and again, OHSS pre-clinic. Are you asking about OPD management of OHSS? I have already covered that. That is for mild to moderate symptoms. Advantage of pulsatile GnRH would be no need of monitoring. And hypothalamic amenorrhea, you are mimicking the normal thing by giving pulsatile GnRH. Yeah. So hypothalamic amenorrhea, in fact, I would put my neck out and tell you the best as according to success rate would be pulsatile GnRH. But is it commonly practiced? No. Pulsatile GnRH will decrease OHSS. See, OHSS is basically increased stimulation to ovary by the pituitary hormones or iatrogenic hormones leading to VEGF. But when hypothalamus is stimulating pituitary, pituitary will never go in hyper way. So OHSS risk could be less, though it is there. In fact, if I point out, highest risk is with gonadotropin therapy, maximum in gonadotropin therapy is with HCG, followed by HMG therapy, yeah, followed by GnRH antagonist therapy. Why not? Antagonists can also do that, yeah, followed by pulsatile GnRH, followed by, I would say, clomiphene now, and least risk would be with letrozole, in fact theoretical risk. Okay, all right, am I clear about this, guys and girls? Thank you so much, God bless you. I have covered it all. If you have any doubts, you know how to reach me. Thank you very much. Bye bye, good night, take care.